Good day, and we warmly welcome you once again to the 2022 UPCM Grand Scientific Symposium. The program is brought to you by the University of the Philippines, Manila, UP College of Medicine, and the Postgraduate Institute of Medicine. The program is back on its second day, and we are proud to showcase not only one, but 3 sessions this afternoon. Our session is enriched by the different specialties we will be hearing from today. Our first will be chaired by Dr. Frederick Gloria, accompanied by Dr. Maria Geraldine Torralba as co-chair, and will feature the notable speakers Dr. Aldrin Loyola, Dr. Veronica Magnaye, Dr. Nilo Flor Cruz, and Dr. Don Paloyo. Dr. Aldrin Loyola is an expert in evidence-based medicine. He is also a holder of a master's degree in business administration and health and is an associate professor of the UP College of Medicine.
Good afternoon. I'm Dr. Aldrin Loyola from the UP College of Medicine. Thank you for the kind invitation to speak during the 23rd Grand Scientific Symposium. Today, I will be sharing with you some of our experiences in internal medicine practice during the COVID-19 pandemic. My conflicts of interest relevant to this talk are listed on the right side of the slide. In the next 10 minutes or so, we will be talking about the effect of the pandemic on patient volume, the practice adjustments made by doctors during the pandemic, the application of telemedicine in medical practice, and we will give particular emphasis on perceived threats in the use of telemedicine during this time, and addressing inequity in healthcare access with particular emphasis on telehealth or telemedicine. The pandemic has reduced the number of patients consulting at practically all local clinics, with as many as 8% of practitioners reporting zero consult at the start of the pandemic. Only 15% of practitioners reported a reduction of a quarter or less in terms of patient load, and a vast majority experienced a reduction of 50% or more in terms of patient visits. Shown in the slide is a report from our colleagues in neurology emphasizing the massive reduction in patient volume at the beginning of the pandemic in terms of outpatient consults and inpatient admissions. Notice the precipitous reduction in the number of cases in the months following the beginning of the pandemic, contrasted with the preceding 3 months. This is likewise reflected in the number of neurology procedures done in the same period. In a survey of local practitioners conducted in October 2020, more than half of doctors, 54% to be precise, more than half of the doctors surveyed said they go to their clinics much less than before, with 35% saying they were hesitant to see patients face-to-face. In addition, 44% have included telemedicine as part of their practice. In the same survey, only a third of practitioners claim that at least half of their patients engage in telemedicine service, with 2 out of 3 practitioners reporting only some of their regular patients consulting remotely. The following are the reasons cited by practitioners and patients when asked why there is low utilization of telemedicine. There is concern about data security as well as privacy. There is high upfront fees on the part of the provider and limited payment options among patients. There is absent interconnectivity between providers and pharmacies for filling of prescriptions. The interconnectivity between providers and laboratories for diagnostic workup is practically non-existent. There is difficulty in patient record keeping, particularly with the limitations imposed by remote consultation on physical examination. And there are problems in user friendliness, particularly when using unfamiliar platforms. The following is data from the US highlighting the number of telemedicine consultations before and after telemedicine scale up in the months following the pandemic. The number of telemedicine consultations before the scale up is marked in blue, while those after the scale up is marked in orange. Notice that despite scaling up the telemedicine services, there was actually a reduction in the number of consults among older patients, among those whose first language is not English, and among Medicare and Medicaid patients. If such inequality can happen in a technologically advanced society as the US, it is highly likely that even more severe inequality may exist in developing countries such as the Philippines. These segments of the population are particularly vulnerable to inequitable healthcare access, which was likely exacerbated by the declaration of the state of calamity because of the pandemic. Older adults, classes belonging to the lower socioeconomic strata, people with limited health literacy, those with limited English proficiency, and racial and ethnic minorities, as well as groups residing in geographically isolated and disadvantaged areas. This is the reality that we often experience. There are a few who were given tremendous advantages and opportunities, and a vast majority who have difficulty just getting by. This sad reality was emphasized even more during the pandemic. They said that we were in the same boat during these difficult times. But I believe that it is more accurate to say that we were all in the same storm during the pandemic. A few were riding on big ships, some were in boats, many were using rafts, and even more didn't even have life preservers. We can try to mitigate this state of affairs by providing everyone with the same opportunities. But this may not be adequate, as some segments of the population will definitely need more assistance compared to others. We should instead strive for a more equitable distribution of assistance, wherein those who need more will receive more, and those who need less will not be given as much. We can address disparities in telehealth by first identifying subgroups who may have limited access and poor digital literacy, and exploring steps to address this. There is a need to monitor the outcomes of such interventions so that we can improve on our measures. We need to address digital literacy and resource barriers by teaching patients the skills needed for remote consultation and informing them of more economical means of internet access in their areas. We need to address health system created barriers by first offering video visits to every patient. Second, ensuring adequate language interpreter access if such is needed. Third, screening for patients at high risk of not being able to engage in video visits, such as those without device or internet or data access, or those who can encounter privacy issues when doing remote consultation. We may offer telephone visits if our patients are unable to do video visits, and we need to increase awareness among the leadership on the barriers to telemedicine. Lastly, we need to advocate changes to support sustained and equitable access to telehealth services by promoting permanent expansion of low-cost or free broadband internet, securing funding for telemedicine expansion in resource-limited health centers, and fair compensation for telephone and video consults by all payers. So what has happened locally? The push of the government and the private sector to improve access to telemedicine by improving access to information and communication technologies is underway. But we can't overemphasize the importance of addressing issues that may worsen disparities in healthcare access, especially among the very vulnerable segments of the population. There is likewise a pending bill in Congress on e-health and telemedicine development, which aims, among others, to promote the delivery of health and medical services through electronic means of communication. Hopefully, this legislation will also address potential sources of even more disparities in healthcare access, particularly among vulnerable sectors. In the last 10 minutes, we talked about the reduction in patient volume brought about by the pandemic, the adjustments in medical practice made by healthcare practitioners, the application of telemedicine in medical practice with particular emphasis on the perceived threats on the use of telemedicine. And lastly, we highlighted measures to address inequity in healthcare access with particular emphasis on telemedicine. Thank you for your kind attention.
Dr. Veronica Magnaya is the Assistant Medical Director of the San Pedro Hospital of Davao City and is the CEO of the Integrated Clinics of Otolaryngology, Head and Neck Surgery, also in Davao.
Good afternoon, everyone. Maayong hapon sa tanan. This afternoon, I am very privileged to be with you to talk about our experience, the ICON's experience through the pandemic. We were given certain learning objectives for this session that are as follows: to list the challenges by the healthcare delivery during the health crisis, to perhaps summarize group interventions, and for us also to be able to review interventions affected by the specialty area of practice, and for us to be able to develop individualized plans to augment healthcare delivery during times of health crisis. Ladies and gentlemen, the 2020 story of ICONS through the pandemic started on a rainy January day. We were planning for a strategic planning at ICONS Incorporated. ICONS stands for the Integrated Clinics of Otolaryngology, Head and Neck Surgery. I was and I still am the CEO today. I was very, very excited to tell my teammates and my colleagues at ICONS about the genius of the and. Alam niyo po yung the genius of the and the tyranny of the or. And we were learning the way that to be transformed at ICONS. We were trying to create an organization that will embody the quality of a living system that is diverse, that is evolving, that is emergent. We were getting ready for very big things in the next 3 years. But lo and behold, ladies and gentlemen, everything stopped because we were called. We were called by the city government. Our ICON strat plan never came to be. It turned out then to be a planning following a Davao City Health Office coordination and orientation meeting that was held for all medical directors, heads of departments, all city health officials, and the Department of Health Region 11 key personnel. We were presented with this slide. Unfortunately, ladies and gentlemen, the colleagues, the physicians in Davao City were all shocked. We were presented with a PUM, and we were being bombarded by referring institution, a surveillance unit. What about the 911? What about the district health office? So everything seemed to have been dictated on us, and we didn't know what to do. We didn't know how to react. This was a collective of physicians in Davao City, ladies and gentlemen, and the mindset that we had was that, and the conclusion from that meeting was, we did not have a plan. Yes, we were bombarded by DOH with best practices, all of these were nothing because the guidelines that were brought forth by government were insurmountable. It was laughable that the public and the private hospitals, we were not ready. We were tasked to look at ventilators, to look at isolation units, but that wasn't really what happened. No, we didn't have any of those, so we were very problematic. On February 12, 2020, another DOH directive. So following January, naging February 12, it was another meeting. This one was the entire early warning device to all health personnel. We knew that we had to get ready and we knew that we had to move forward. Why? Because this was a very serious directive, no? There is no sufficient cost to refuse COVID-19 patients and PUIs seeking consult and treatment in hospitals. The Davao City health systems, we were not ready. So at Icons, we also put this directive or this memorandum very seriously. The checklist that was applicable to all hospitals, we applied it to us at our ambulatory surgical care unit. We looked into the activation of the Hospital Emergency Incident Command System. So ito pong pinamimigay ng Department of Health para sa level 2, 3 na hospital, we tried to apply it to us. So that was what we initially did, no? And sad to say, ladies and gentlemen, the checklist, we were a failure at this checklist. You know how it is with DOH. They're very fond of checklists. And gano'n naman talaga eh. Itong mga to, surveillance and reporting, risk communication, advocacy, community preparation. We tried to put that for Icons, no? In-apply po namin ito sa aming maliit na ambulatory surgical care unit. Hindi ho kami pumasa, no? So talaga hong napakalaking dagok po noon at that time, no? The first 2 weeks of February, because we were scrambling. We were scrambling for good policies and procedures for the ambulatory center. We were all scrambling in our big hospitals in Davao what to do because we had no plan. As I'm sure you will be able to relate, no? You know what I'm saying, that the realization that our health system is fragmented and fragile really came like it was a door that was hurled at you. This realization made us panic. What with the resources we had available, we exhausted each and everything that we had, and it was tough. Nonetheless, at Icons, we had to have, instead of an LED billboards that will be up for the next 3 years, it was a mini tarpaulin. Tarpaulins to say that your EMT is in, tarpaulin to say that you be safe, you make an appointment. We were getting ready. In fact, ladies and gentlemen, we even had a washing machine delivered to Icons. That level of thinking into the detail, we had it. Why? We immediately summoned our clinic manager and our staff, our nurses, have PPEs ready for the ambulatory surgical unit. We purchased initially raincoats. We also had impermeable cloth PPEs made. We stacked up on everything, OR supplies, gloves, masks, and all other needs. We were probably the first ones to get cleaning supplies and new sets of OR linens. We had OR linens made ASAP in the first 2 weeks of February. Yes, we bought a huge washing machine, an industrial washing machine for all these, no? Disinfectants, detergents, liters of alcohol. All prep was done in February. And then the first day of the lockdown, March the 13th, We really did not know what was to happen, but we knew that we were prepared at the ENT center. We also prepared our employees. So this was our so-called aprons. We had to buy shower curtains from SM. And then this is our manager who had to put up with us in really looking for somebody to to make our PPEs. No, this is our nurse Darlene and Dr. Yara. We also had to educate everybody in the staff how to don PPE safely, how to doff BPE safely, no? So donning and doffing, that was an everyday thing at Icons even prior to the lockdown. We prepared with gear. We also, aside from the face shields, because otolaryngology necessitated airway management, we needed to also see our patients of the head and neck. We had PRs delivered to Icons prior to everything and anything, no? And thank you to Justin Paber and Oletan. We had an endoscope splash guard. No, thank you very much to Zamboanga Medical Center and Justin. The innovations are truly worth this for us, the ENT. It is very comforting to know that we have colleagues who design these things for us. Again, checklist number 2 was disinfectants. We had a lot of it, ladies and gentlemen. Administrative controls, of course, clinical triage, infrastructure and activities, waiting areas with adequate space for patients, with social distancing and ventilation, not to mention flow. No, so we were very aware that the DOH knew of flow, proper scheduling of patients, adequacy of healthcare supplies, etc., etc. We had triage that changed every so often. No, this is the algorithm from PISMID. This was given to us in the last week of January. We actually ignored this for a while, but we had to review it over again, no, at Icons. We were lucky we had an entire building. The first floor on entry was triage. The second floor was all of our clinics. The third floor was our waiting area. We had plenty of space. So we were very lucky. The doctors who had clinics in hospitals moved to Icons, no, to the ENT center, and we all were there, no. Iba-iba lang araw, no, para hindi naman ho kami masyadong exposed sa COVID-19. The fourth floor was for laundry and for all our other supplies. We prepared our employees. We provided transport and living quarters in the building. We stayed informed of protocols. Little did we know that these things were very, very helpful to all of us because we were fine. We were okay. Hindi naman ho kami nagkaroon ng maraming COVID infection sa Icons, no? We followed everything in the community, and what would the mayor say in Davao, we had to follow. In fact, there was clustering of districts for food and medicine pass. So alam naman po namin ito, no? Kanya lang, yun nga, in Davao, it was a very good one because we had one COVID center. So all you needed to do was get into the hotline. Everybody gets into the hotline. The hospitals would also have an algorithm for their COVID patients, whether this is an emergency or an non-emergency. You really needed to call the hotline if this is a patient who is COVID, no? The Office of the City Mayor of Davao would release these, how do you call this? Memorandum of memos, no? Of course, also, we have to thank her, the city mayor, because of the One Hospital Command Center, as SPMC was dubbed then, and because of her faithfulness to keeping meetings every week for a long time, when we had insecurities, when all of the health personnel needed to have transportation when we needed. The hospitals needed oxygen. So we were very lucky our city mayor was there all the time, no? So yun siguro yung advantage ng Davao City. Ang dali-dali ho naming nakapag organize, no? Major hospitals, small hospitals, ambulatory centers as ours, we were able to organize very, very well. And it was, for us at Icons, it may not have been really business as usual, but we were open for our otolaryngology patients. Of course, there was also this coronavirus tracker. Every week also, my hospital, San Pedro Hospital, would come out for air algorithm for triage. And at the height of COVID, there would be a lot of consultation advisories, week in, week out. SPMC and IDS people in Davao would give updates on consultation advisory. And of course, for the healthcare worker, we were very much in touch as to what to do. The IDS people in Davao work very, very hard. We have to give that to them. No, we work very, very hard as a team. Alam na po namin yung return to work criteria for healthcare workers because our IDS would always be present in a whole lot of meetings. Icons remained open. We didn't have any choice but to open every day, because there will be nowhere for patients to go, no? Nowhere for head and neck cancer, nowhere for infections. Ang mga malalaki pong ospital, mga 5 pasyente lang kada doktor o kada espesyalista ang kinikater. So sa isang floor ng ospital, kaunting-kaunti lang po yung pasyente. Icons really, we never really close, no? We catered to infections and tumors. We had to put up some time and some creativity how we may be able to accommodate intravenous injections at the very least for the first 5 to 6 hours. Kailangan naming mag-IV line, no, para lang ma-accommodate yung mga pasyente na hindi naman COVID pero infection, no? Icons is an ambulatory surgical center in Davao for otolaryngology, head and neck surgery. We are DOH accredited. We are PHIC accredited. Nagsuffer yung hearing diagnostics, nagsuffer yung vestibular diagnostics, even sleep. But we, as an outpatient clinic, as an outpatient surgical center, we had patients, no, all the time. No? So this is Dr. Yara. We were very lucky. That single time that we had to shut down was only for 7 days when we had symptomatic employees, no, very early in 2021. But at that time, we were now very much an expert on protocols. None of our staff nor our Icons MDs had more than a mild COVID infection, if we ever did have one. That single time, that was really a freak, no. We were just trying to be very cautious. Pero hindi naman ho kami na ospital or what. Very, very mild. Our physicians, Dr. Yara, Dayanghirang, Matias, Bagindali, Katsuela, Laganao, and Elefante. What were our lessons? Be prepared at all times. Educate all members of the staff. No compromises on administrative controls. Follow ever-changing protocols. Be in the know and involve yourselves in the community and cooperate. Our immediate outputs: policy on response to emergent and re-emergent infections, policy on community crisis and emergencies. Nagkaroon ho kami nito kaagad-agad, no? What were our lessons in Davao? The vital components of the fight is leadership. Perhaps a systems thinking approach to the community crisis. Think of it as a whole. Think of infrastructure, hospitals, transportation. Think of the healthcare worker, all your other resources and policies. Make interventions known, no? Clustering and barangay involvement would have been very, very vital. What were also our general lessons as a community in Davao? Weekly meetings and constant communication with the DOH, the city health units, and the city health officials. The city mayor and her staff were very crucial with our COVID-19 success. crucial for reporting, planning, and evaluation. Government and NGOs were in close coordination with each other and the city officials. Hospitals had confidence that there was genuine help from government, and the healthcare workers were all taken care of, and quick response from all. With this slide, ladies and gentlemen, I'd like to thank all of you for your time and for listening.
Dr. Nila Flor Cruz is the president of the Philippine Glaucoma Society, a fellow of the Philippine Academy of Ophthalmology, and an associate professor of the UP-PGH.
Good afternoon. I would like to thank the organizers of the UP Grand Scientific Symposium, particularly my co-mentor in IPC, Dr. Frederick Gloria, for inviting me to deliver this lecture. I am connected with the Department of Ophthalmology and Visual Sciences, UP-PGH. I am part of the LU7 Interns Committee of the college and also a consultant of the Glaucoma and Cataract Division. I am also a glaucoma and cataract consultant at the DOH Eye Center, East Avenue Medical Center, and lastly, I do my private practice at the American Eye Center as a glaucoma and cataract specialist. Here is the outline of my lecture. I'll be sharing with you some learnings as well as my experiences in the three institutions where I am connected. On March 16, 2020, an enhanced community quarantine was declared, which took effect the following day. This was 2 days after President Duterte announced a community quarantine, which differentiated from a lockdown. Frenzy of panic buying of food, toilet paper, and immigration and emigration from Metro Manila started. Back then, our family had just moved into a 2-bedroom condo unit in Pasig City. My wife, who came back from travel by the end of February, started her quarantine at home. She's a senior manager in TV broadcast company, and she was able to do her job of negotiating contracts with pay TV operators in different countries at home, virtually. In effect, she already started quarantine prior to March 17, 2020. My youngest son, a second-year health sciences student at the Ateneo de Manila at that time, was on a wait-and-see mode for further announcements from the university. As for me, I was not able to hold clinics and see patients at the three institutions where I am connected. The world seemed to have gone to a full stop. We rationed food and embraced the fact that there were nights when dinner was siopaw and Lucky Me. Our main activity then was marathon, Netflix marathon. The lockdown presented the opportunity for us to catch up on popular Korean novellas such as Chloe, Something in the Rain, and repeated watching for the nth time our favorite Mr. Sunshine. At one point, we hoped that the lockdown would be over by the time we finished watching one of the drama series. But lockdown continued extension after extension, and there were too many Korean dramas to pass the time. During the ECQ period, I heard from a radio interview of former Senator Eddie Ilarde that the pandemic was comparable to a world war. But the difference is that we cannot see our enemy. He may have experienced World War II, but my generation, I was born in 1973, did not experience World War, only coup d'etats, typhoons, and earthquakes. Following that train of thought, I compared the pandemic with an atomic bomb explosion, like a giant mushroom cloud claiming the initial damage made. This is the first wave that hit the world. The Department of Health started monitoring the number of COVID positive patients. At this point, there were frontliners in our profession who succumbed to COVID. Many of them were our mentors, and some were younger than me. For ophthalmologists, we took a longer pause. Life versus limb versus sight. It's like letting the mushroom cloud settle first before going to war. It was also comparable to the second line of defense during the traditional war. The next slides will give my story as an ophthalmologist who eventually conquered COVID. Let's go to my UP-PGH experience. On March 30, 2020, just a few weeks after the ECQ, Philippine General Hospital was declared a COVID referral center. There were oppositions to this as it will affect the training of some of non-COVID related specialties. But personally, I agreed with the decision. Dapat lang. The swiftness of the action may be attributed to the fact that PGH was under UP and not DOH. Of course, there was the support from the Office of the President. With PGH as a COVID referral center, ophthalmology took a backseat. Our residents and fellows took part in manning the COVID wards. Our OPD and operating rooms for private and charity patients closed. This was during the ECQ, which extended up to the end of May 2020. The training committee extended all residents and fellows to an additional year. The department did not accept new residents for 2021. It took a while before ophthalmology in PGH to restart. After getting adjusted as a COVID referral center, the clamor to open non-COVID related operations started as there was a need for them. Adjustments to the new normal were made. An electronic medical record system, which has been a dream for a high patient volume department, became a reality. Appointment system, which was unheard of in a government hospital, was initiated. Although not very compatible with ophthalmology, teleophthalmology was started. Eventually, initial consults were done via telephone prior to face-to-face consultation. At this time, a resident of mine involved me in the protocol development of COVID-related eye symptoms. We were able to have it IRB approved and data gathering started with the use of full PPE in the wards. It was a prospective observational study. Other residents continued to develop their research protocols. IRB meetings became virtual with an almost perfect attendance during monthly full board meetings. Surgery and consultations started slowly for ophthalmology as the patients and residents adjusted to the new appointment system and EMR. Eventually, our department conferences were held via Zoom. During ECQ, the interns committee met on many occasions to discuss how the class 2019 to 2020 interns could finish their rotations. For ophthalmology, instead of interns presenting cases during small group discussions, we developed simulated case for them to discuss with a consultant. Definitely no face-to-face rotation for ophthalmology and even the major specialties at that time. Just like in the people power revolution, there was leniency in the requirements. Face-to-face experience had to wait until vaccine became available. Fast forward, and as of today, consultations and surgeries are nearly of pre-COVID numbers. Interns man the OPDs and ER. Our conferences just started the hybrid platform. The SGDs of interns remain on virtual mode, but the attendance of consultants is 100%. So here are pictures from the UP-PGH. No? Seen in the slide is PGH Director Dr. Gap Legaspi at the command center of PGH. On the right are hospital beds donated by private institutions in the COVID wards. More pictures. No? On the left is a picture of with our residents and fellows manning the COVID wards on full PPE. And pictures on the right shows our residents and staff on PPE upon restarting of the operations at Centro Oftalmológico Jose Rizal building. How about at the DOH Eye Center? Compared to PGH, firm decision to declare the hospital as COVID referral center right away. East Avenue Medical Center, Dili-Dalin. The hospital was under the DOH, and one of the reasons for healthcare to all subspecialties, one of the reasons was for healthcare to all subspecialties to continue. Our mandate was business as usual, although in a smaller volume, strict protocol compliance. The DOH Eye Center only closed for a few weeks. An operations manual was developed during ECQ, which was modified in parallel with the changes in quarantine level. Ophthalmology continued after 2 weeks. As the world stopped, trauma cases were hardly seen, but urgent glaucoma and retina cases, such as angle closure and diabetic retinopathy, were treated by the center. Surgeries continued following the PPE level required. Our operating rooms were divided into local and general anesthesia rooms. Of course, only negative PCR patients were operated on. Elective cases, particularly cataract and pediatric, halted. Ophthalmology residency training and fellowship programs were also extended for 1 year. And the residents were also required to man the COVID tents with full PPE attire. After the initial hard lockdown, I was able to go to the hospital and met with a few brave consultants and also saw residents and fellows. I was able to assist a few surgeries at a time where vaccines were not yet available. The DOH Eye Center received lots of donations, PPE, alcohol, medications, and food for the staff. The Bayanihan spirit was there. Telemedicine, appointment system, and digitization of charts were also instituted at the center. Patient load and surgeries gradually increased with a few lockdowns in between. Surgeries were prioritized and eventually started. As of preparing this deck, I can say that DOH Eye Center is almost comparable to pre-COVID numbers. My senior residents have each done 80 to 90 cataract surgeries. Here are pictures from the DOH Eye Center. On the left are the directory of the residents and fellows on full PPE. And seen is our slit lamp. No, you can see our modification with that bulky shield. And we have 2 photos wherein we were doing ophthalmic surgeries during the pandemic with full PPE. Now, let's go to my American eye practice. I can say that I am very fortunate to be connected with UPPGH and East Avenue Medical Center. For government hospitals, doctors are still on no work but with pay scheme. Fact is, we have families to feed and amortizations to pay. My private practice stopped as soon as lockdown was instituted. I am connected with a group practice at the American Eye Center with 2 branches situated at Shangri-La Plaza and Greenbelt 5 malls. During the hard lockdown, rental fees were waived, but we continued paying for the electricity and water or the KUSA. Our eye center's employees also have families to feed. Around the 3rd week of May 2020, with the opening of other non-COVID health services, the American Eye Management Committee, with the support of eye doctors and staff, started clinic and eventually resumed surgeries. We initially opened our Shangri-La Plaza clinic and attended to urgent cases. At that time, only health services and the grocery and True Value were open in the mall. Air conditions were set at warmer temperatures. Prior to the pandemic, we already had the appointment systems and digitized medical records. Adjustments were only made on the examination rooms by providing air cleaner, slit lamp shields, contact tracing policy, and PPE requirements. As soon as we saw patients, we were able to schedule surgeries, initially urgent cases like retina, glaucoma, and cataract. LASIK surgeries followed as quarantine levels were relaxed. At the start of the pandemic, we were brave enough to do PCR testing for the local procedures that take 15 to 20 minutes. The patients were on tape KN95 masks and do away with oxygen cannulas. Actually, I felt safer at the operating room than in the examination rooms, where there are a lot of talkies with the patient. During the Delta wave, where the positivity rate was very high, we required RT-PCR tests. Eventually, antigen tests replaced RT-PCR for local surgeries. Of course, RT-PCR was required for all GA cases, even until now. We did not experience an outbreak at the operating room until the Omicron variant arrived in January. That was then the staff and the doctors and the scheduled cases were 50% positive. Prior to the pandemic, the American Eye Center has been contemplating on transferring to another mall at the podium. We plan to consolidate and centralize our operations under one roof. With courage and determination, we were able to build and transfer to our new home. With the Omicron wave last January 2020, our operations were abruptly stopped in the first week of the year. It was only in March 2020 when we started clinics, and by April, surgeries resumed. Given that more people have started become more health conscious, our census today is way more than the pre-pandemic numbers. During the pandemic, and in spite of the heavy cost-cutting measures we implemented, we did not fire any of our staff. We were able to provide for all of them even during the times when we did not have clinics and surgeries. Shown at the top are my American Eye colleagues, and videos below, as we got to try the 3D technology, wherein we don't have to use the oculars of the surgical microscope in our cataract surgeries. That's the left video. It is a very expensive add-on toy. On the right shows modification with the draping of LASIK patients. Take note of the extension of the drapes towards the chest of the patient. More pictures from the AEC team that's in our lounge with the doctors, and you can see the polycarbonate divisions made. On a personal note, what made me survive the pandemic and continue on? As I told you, I owe my sanity to internet connectivity, which enabled me and my family to spend time watching programs on Netflix, Amazon Prime, HBO, and View. It was during these times that I learned how to cook rice, do the laundry, wash the dishes, and vacuum the floors. Of course, with a little help from our home buddies, the rice cooker, washing machine, RoboVac, and dishwasher. Personal health, or the popular hashtag self-care, is very important. During ECQ, when we were not allowed to go outside, my wife and I jogged in the basement party or sneaked at the fire exits to climb the stairs in our condo. Eventually, we were able to play tennis at Celebrity Club without masks, except during the Omicron wave. I was able to play golf around September 2020 with a caddy just watching my golf balls. If you're looking for activities that are low risk for COVID, golf and tennis are at safe levels. Recently, I did my first face-to-face SGD with the interns. So, what's my take-home message? Once a person experiences grave danger, there are two natural human reactions: flight or fight. Although the ophthalmologists are not at the very forefront of the battle, many decided to fight, armed with the science of wearing masks, courage, and call to arms, call to serve the people. We decided to join the battle to beat the pandemic. We are almost there. Thank you.
Dr. Don Paloyo is a transplant and vascular surgeon, a fellow of the Philippine Society for Transplant Surgeons, and a clinical associate professor of the UP-PGH.
Thank you for that brief introduction. Good afternoon, everyone. I would like to thank the organizers for inviting me to speak at this year's Grand Scientific Symposium. I am Dr. Don Paloyo, and my talk is entitled Pandemic Surgery, resilience amidst the new norm. So over the next 15 minutes or so, I'm going to talk about the challenges we faced going into the pandemic. I'll describe the interventions done by the government, the DOH, as well as PGH in response to COVID-19. I'll also discuss some of the societal interventions, particularly guidelines and recommendations when resuming surgical operations. Lastly, we're going to talk about resilience. Now, maybe here is where I give my disclosure. Obviously, I'm not a psychiatrist. I don't have any background on psychology, nor claim to be an expert on this subject. Basically, what I'll show are just ideas that I came across the internet and some personal thoughts on the matter. So let's start with some statistics. We are now 110 million population. Almost half of the population is below the age of 25. Over half are residing in urban areas. Females tend to live longer with a life expectancy of 73 years and 67 years for males. We have an average of 10 hospital beds and 6 physicians per 10,000 people. Now, these are mostly concentrated in urbanized regions, such as NCR. And so far, we have a total of 2,300 critical beds, ICU beds nationwide. And so that's where we're at, as far as resources are concerned. Now, our health system is highly decentralized and devolved. Although the DOH is the lead agency involved in leadership and governance, the governance of localities, health services delivery, has been largely relegated to the LGUs, all because of the Local Government Code of 1991. Since then, we have made significant strides in advancing universal health coverage with UHC Act of 2019. This act aims to ensure that the Filipinos gain equitable access to quality and affordable healthcare. But despite these reforms, challenges still remain, such as highly fragmented care, maldistribution of health facilities, health human resources, as well as financing. Furthermore, we are facing a triple burden of disease, composed of communicable and non-communicable diseases, as well as disasters. So these deficiencies, coupled with the triple burden of disease, poses a challenge in priority setting, not only in terms of financing healthcare, but also in the delivery of services and implementation of programs. This proves to be even more difficult in a health crisis, such as COVID-19. Where existing inequities were further exposed. It is also worth noting that the LGU's preparedness plans are designed for natural disasters, not epidemics. And so this is our situation going into the pandemic. We were really quite in a pickle in so much as we were stunned, at least initially. I think everybody went into survival mode because everything was happening so fast. And March 1, 2020, the World Health declared that we indeed have a pandemic. This was the day that changed our lives. Masks, fist bumps, elbow bumps, and virtual platforms were now the norm. So how did we respond to this? Well, first, we had travel restrictions, which were imposed early on. The government conducted contact tracing. We had travelers from restricted countries undergoing 2-week quarantine. So these restrictions were successful in delaying the spread only briefly. Metro Manila was placed under ECQ. We were in strict home quarantine. We had suspension of classes. We started doing work from home. So putting the whole of Luzon on ECQ. The good thing, though, the ECQ gave us the opportunity to mobilize resources and organize our pandemic response. We had daily press briefings, TV, internet ads, and infographics on social media. However, there were still a lot of misinformation and conspiracy theories about COVID-19, which was particularly challenging for a population that spends more than 10 hours a day on the internet. These challenges became increasingly difficult to correct. The government also resorted to testing, but was done on a small scale. Only RITM was performing the tests initially. And so overall, our initial response lacked organizational preparedness. Furthermore, our primary care system did not serve as a primary line of defense, which was actually the aim of the LGU, the Local Government Code. What happened was people went straight to hospitals in urban areas, no? Overwhelming our critical care capacity. And so what was the PGA strategic plan like? Well, we first we established a command center which coordinated all admissions, no, especially COVID transfers. We created a crisis management committee. No, this committee was a triumvirate, no, having an overall operations head, a manpower head, and a logistics head. No, their most important objective was to protect the healthcare worker. HICU handled the science, no, the protocols, policies, SOPs. The IEC was responsible for internal communication. No? The two big goals of this committee were to prevent the crisis of confusion and keep PGH healthy. No? The Telecomusta technology, no, was created, no, wherein families can see and visit their loved ones. No? Radish, carrot, okra were now familiar dishes, no, in the PGH electronic menu. Form before function, no? And all hands on deck were guiding principles of the Manpower Committee. This meant that staffing estimates, no, from physicians all the way down to the cleaners, no, were made. It also meant that we are always ready to pull out staff, no, from the other departments if need be. PGH was, and will always be, no, a magnet for donors, no, to ensure watching. No, we had to reprogram our savings. No, we had to cut off some regular services. The government, no, directed agencies to cut their MOOEs, no, to redirect them to COVID referral centers. No? And lastly, donations of private organizations and individuals came at the most appropriate time. And so overall, PGH did its best, no, to prepare given the limited time and resources. No? Ours was not a perfect one. There were certainly aspects that could have been improved. However, it brought forth many best practices, no, such as technological innovations, resilience of the staff, and the Bayanihan spirit of the community. No? Now, there's a nice paper that came out from Dr. Jean Toral, which was published in ACTA, no, last year. And if I may quote their conclusion, no, the true test of hospital preparedness may best be measured not by any checklist, no, but how much it has protected its personnel and by the delivery of care. As for the Department of Surgery's response, we were forced to postpone our elective cases and limit ourselves to emergency cases only. However, 2 to 3 months into our COVID operations, it became clear that we cannot limit anymore our ORs, no, as backlogs of patients were piling up, particularly non-COVID patients, no, with malignancies, cardiac patients, dialysis patients. We had cancer patients coming to the ER with disease progression and surgical abdomen. And so resumption of OR services became imminent. No? This was on June 4, 2020. Around this time, surgical societies started coming out with guidelines, no, on the resumption of surgery, such as the American College and the Philippine College of Surgeons. These guidelines put value on the individual institution's COVID capacity, ICU bed and ventilator availability, and level of supplies. No? Having a multidisciplinary team, no, became essential, if not mandatory, no, particularly in cancer cases. And so here is a flowchart of how we process our elective admissions. No? We relied heavily on OCRA, where patients register for an appointment and consult. Patients will eventually will have a face-to-face consult at the PATEC, where preoperative risk assessment by medicine and anesthesia are done. Prioritization is done through the MENS scoring system. And then a schedule is then arranged. Patients and watchers are swabbed a few days before admission and then admitted and finally operated on. No? While remote consultation provided safe conditions, no, there were certain limitations. No? One, we were unable to build rapport, no, with the patients and their families. Number two, we were unable to do a proper physical exam. No? There were also issues on connectivity, no, or poor signal, or individuals, no, who were not adept in using smartphones. As for our local society in transplant surgery, we also put forth our guidelines. No? We relied heavily on the local institution's capacity to deliver the service. We also relied on the gene expert system for our swabbing needs. We categorized patients into low and high risk recipients. No? We had them on mandatory X-ray 3 days prior. And we relied heavily on telemedicine as well. No? We pretty much went along with the other societies' recommendation, no, as far as timing of COVID-19 vaccination is concerned. I think this was 2 weeks prior to contemplated surgery. No? So after 2 years, I would say that we are still practicing with uncertainty, whatever specialty you're in. For transplant, we still need to determine, no, the optimal screening and prevention strategies. We need to know our outcomes, no, pre-donation, perioperative, and post-operative COVID-19 infections. Whether the pause in transplant benefited or harmed our patients. No? How efficient was our telehealth platform? We need to determine the optimal immunosuppression for COVID-19 recipients. And more importantly, we need to find the best treatment for COVID-19 among transplants. No? How safe and how effective are the vaccines for the transplant population? No? So COVID-19 has presented us with unprecedented uncertainties across the spectrum of our practice. Right now, we are learning from case series, no, registry reporting, shared experiences, and consensus recommendations. I think it's also about time that we include transplant patients, no, in research study population. Okay, so we're heading to the last part, and as I mentioned, no, at the start, I don't claim to be an expert on this topic. Webster defines resilience, no, as the capacity to recover quickly, no, from difficulties, no, being able to cope and able to withstand adversity. There is no cookbook really, no, for building resilience. No, it is not something we're born with. No? It's built over time as the experiences we have interact with our individual genetic makeup. No? That's why we all respond to stress and adversity differently. No? We can think of resilience, no, as a seesaw, no, or a balance scale, no, where negative experiences tip the scale toward bad outcomes, and positive experiences tip it towards good outcomes. No? Everyone's fulcrum is on a different spot, no? Which explains why each person is different, no? On how we overcome hardships. No? 3 ways we can affect the balance is: 1, you can unload the negative side, no? Reduce the sources of stress. Number 2, load up on the positive side, no? Or build supporting relationships. And number 3, move the fulcrum, no? Strengthen your core skills. And so I thought this is a nice, simple way of looking at building our resilience. Now, resilience is not purely an individual characteristic. No? It is also heavily enabled by strong relationships and networks. No? We can build resilience through a wide variety of interactions with people. No? These interactions help us shift or alter the magnitude of the challenge we're facing. No? They can help us find a meaningful purpose, no? or redefine our purpose, or help us see a clearer path. People in our support system can provide empathy or make us laugh. No? In short, resilience is not something we need to find deep down inside ourselves. We can actually become more resilient in the process of connecting with others. No? A systematic review actually came out early this year, no, which highlighted these 6 themes. No? Now, if you take a look at these themes, no, most of them I think we have right here, no, in PGH. No? Most of us certainly felt having a moral purpose and duty. We had connections with other essential staff. We fostered collaborations, no, with other agencies. We had an organizational culture that was spearheaded by excellent leadership. No? My point really is that looking back, we may very well have been on the right track, no, from the get-go in building our resilience as an individual or as one community, no, in PGH. Just one final note before I end this talk. Let's not wait for things to get easier, no? But rather let's learn to handle hard better. When we were into residency, we would say after training, life will be easier. No? When we became consultants, we thought now life is easier. No? Actually, no, it doesn't happen that way. No? So we need a mental shift, no? From wishing, praying, hoping things to get easier, no? And shift to handling adversity better. Is it a gradual shift or is it an abrupt shift? I don't know. No? But what I do know is that those individuals who handled the hard things better came out being more resilient. So I would like to summarize my talk in 5 points. No? First, going to the pandemic, no? The Philippine government's response lacked organizational preparedness. Its indirect health impact, no, in the long run remains to be determined. Secondly, PGH did its best, no? Given the time and resources. No? Certainly there was room for improvement, But at the end of the day, we can say that all our efforts pulled us through. Third, as we recover, lives have been forever changed. A new norm has been set, no? Masking, physical distancing, and hand washing. Fourth, we may have resumed our practice, but we are now practicing with more uncertainty than ever before. And lastly, resilience was built in record time for some, if not most of us. Collaborations and networks were forged. These newly established connections and friendships were crucial in building our resilience. So 2 years into the pandemic, and I mentioned this in the previous slide, many of us are forever changed. I think we as a people are different. Some of us have learned different ways of working, different ways of living, and different ways of appreciating things. Some became closer with their loved ones, while some committed themselves to self-care. Some made sure they had ample mental space, and some redefined their purpose in life. As for me, it's finding flexibility. With that, thank you for your time and attention, and I'd be happy to answer some of your questions. Thank you.
We also have none other than Dr. Anthony Cordero, Associate Professor 7 and Director of the Community Health and Development Program, as the moderator.
Okay, magandang hapon po. Good afternoon, everyone. If you have questions or comments, you can just type them at our chat box or Q&A. And while waiting for the questions to come in, we have a question for Dr. Magnaye. At the height of the pandemic, how did you determine which patients should be prioritized for certain ORL procedures, even if it places you at high risk for COVID exposure?
Thank you for that question. How did we determine how to prioritize? Really, if it were an emergency, talaga pong level 4 PPE, how did you it would still be how emergent and how urgent the case would have been. Frankly, wala naman hong magagawa yung ORL at saka yung anesthesiologist kung emergency, di po ba? Kung otolaryngology ang pag-uusapan at airway yung pag-uusapan, kung kakailanganin po ng tracheotomy, kung kailangan pumasok ng OR, we were really pushed against the wall on this. We were just very, very lucky that hospitals in Davao were very cooperative. Our administration, together with government, talaga pong we were provided with everything. Hindi naman kami pinabayaan. But really, if it were an emergency, it would really have been priority. Wala kung infection in mga incision and drainage, papasok pa rin po ng OR. Kung airway, papasok po talaga ng OR. Naka-level 4 PPE lang po. We were really plainly lucky, I think. Very, very lucky, really.
Okay, maraming salamat, Dr. Magnaye. Actually, the presentations were very varied in a very, very good way. We were able to see an LGU hospital collaboration in one of the presentations. That's meron ding parang focus on government hospitals and comparing it with private institutions. Yung isang question po sa Q&A ay medyo ito po. Good afternoon, doctors. Ano na po ang process ngayon just in case magpapa-opera po sa UPPGH? From the province po yung patient. Ayan. Konsulta. So, sino sasagot sa So, Dr. Paloyo, bigyan natin ang number mo.
Good afternoon, sir. Yeah, so
Ano daw ang proseso?
Yeah, I think almost bumalik na tayo, sir, dun sa pre-pandemic. The OPD is now open for consultation. So I guess they can go straight na dun, sir, sa OPD, I've been to the OPD, ang dami na rin pasyente ngayon kung mapapadaan kayo doon. So pretty much parang pre-pandemic na rin. Of course, may mga may mga signages naman na dun, sir, na pwede na kung saan kayo pupuntang clinic. So yeah, just go straight to the OPD.
Ayan, maraming.
Hello? No?
Ayan.
Yeah.
Dr. Paloyo, meron na rin isang question. With the time that has elapsed since the resumption of transplant surgeries, are there already some answers to the uncertainties you presented in the field of transplant surgery, John?
Yeah. So, great question. So, I think meron na rin mga, may data na rin, no? Especially, sir, dun sa treatment, no? Treatment for COVID-19 among transplants. One is remdesivir, no? If you would remember, no, remdesivir was parang nasimulan ng mga gamot for the general population, no? Not only for transplants. But ang issue kasi sa remdesivir at that time, early on, was you can't use that for patients who have low GFR, no, yung mga ESRD patients. But recently, I think may paper that came out from Spain, giving remdesivir for transplant patients, and they found out that giving remdesivir early on, I think less than 7 days, would provide some benefit in terms of mortality for organ transplant patients. And secondly, another data that came out was yung sa tocilizumab. I think yung mga ibang internist partners natin are familiar with giving tocilizumab in their patients, no? But sa transplant patients, merong dalawang RCT, sir, na lumabas na yung Covacta and another one from MassGen. But their population were not transplant patients. Their population was, I think, general ICU patients. And they found out that giving tocilizumab did not provide benefit, no, in terms of mortality. So I think yun yung dalawang recent data with regards to treatment. And i-add ko na lang din, sir, I think locally there was a paper from NKTI, but these are not transplant patients. These are dialysis patients, no? Who they studied their outcomes, no, on COVID-19 among dialysis patients, and they found out that those who were on hemodialysis and those who were just started initiating dialysis had a higher rate of mortality. So I think yun yung pinaka-bagong data, sir, with regards to transplant and dialysis patients.
And maraming salamat, Dr. Paloyo. There's a question for our 4 speakers. During the pandemic, sobrang isa pang pandemic yung misinformation. So pwede po ba daw ma-share yung 4, yung maybe 2 or 3 per speaker, yung mga most parang unusual or strange questions that were asked during a consultation this past 2 years, and how were you able to respond to those really difficult questions na basically wrong information na ini-insist po sa inyo? So siguro po simulan natin po kay basis na lang po natin randomly yung gallery na nag-appear sa laptop ko, no? So Dr. Loyola, Dr. Magnaye, Dr. Flor Cruz, and then Dr. Paloyo. Dr. Loyola, sir.
Thanks for that question. Well, one of the stranger questions really that was often asked at the clinic was about vaccination and the potential ill effects of vaccination. Maraming natatakot dahil uh, marami raw side effects. Yung iba takot maging ano yung karaniwan nilang fear. It's baka raw sila maging zombie or something like that. No? But I think the problem was that we need to develop the vaccines quite fast, quite rapidly. And so the element of a long clinical trial to test its efficacy and safety was really not present. So there was really some questions about the safety and efficacy of the vaccines. But then we need to balance that with I often have to explain to my patients, kailangan po natin yung i-balance with the benefits of the vaccine. Hindi lang yung harm or yung risk yung kailangan nating tignan kasi na-overwhelm na yung ating health system. So kung magkasakit ka, wala tayong bed for you. Wala tayong ventilator for you, wala tayong oxygen for you. So prevention is really a really a good bet. No? It's probably better. It's most probably the better option, despite some uncertainty about safety and efficacy. And the use of the vaccines throughout the past couple of years have proven that. Now, although there are some safety issues, and we won't deny that, it's very rare. It's very rare. The advantages of having the vaccine really outweighs whatever harms or potential risk patients may face.
Ayan, thank you very much, Dr. Loyola. Dr. Magnaye?
Sir, wala ata akong na-encounter na napaka-weird na question para sa amin. Siguro yung mga questions na na-encounter namin or ko in the past years with COVID, maybe the after effects of COVID, what truly are effects of COVID in the long term. To me, that's very difficult to answer kasi nga, di ba, at that time, nobody had answers. So that wasn't weird, but that was difficult. That was difficult to answer. What are the long-term effects of COVID? Hindi ho siya weird. Valid siya. Number two, at that time na hindi pa natin masyadong gamay na ang dami-dami palang variants. So pwede ka bang magka-COVID ulit? So yung mga ganong bagay, no? And of course, number three, siguro hindi weird pero logical pa rin. If I have COVID in my family, will I have the same, will my family members have the same symptoms as I did? So those are perhaps the questions that were truly valid in the first few weeks of battling the war with COVID, no? Nung mga early pa, but nung ano na tayo, nung mga 6 na buwan, 8 buwan, mukhang nagiging mas clear na yung I don't know what's clear even today, no? So however, we were getting to be comfortable enough to become the physicians that we'd like to be delivering, no? So siguro yun po yung mga questions na we encountered in the past, no, na dapat nasagot at hindi naman weird, no? Thank you, sir.
Okay, thank you, Dr. Magnaye. Mga toxic questions, no? Parang guwasan hall lang ang dating habang tinatanong ka ng pasyente. Okay. Dr. Flor Cruz?
Sir, sa practice ko, ang isang weird is, kinoconnect nila or tinatanong nila kung lalala ba yung glaucoma nila pag nagka-COVID sila. So, isa yon. So, kinoconnect nila sa lahat ng disease yung COVID, no? And yung second na maraming tanong is, merong either after surgery, tinatanong nila sa reception namin is pwede po ba sila magpabakuna after surgery? No, which is, oo naman. Kasi sayang yung schedule, lalo na nung una, di ba? Pag nakaschedule ka na, tapos biglang parang nag-hesitate sila kasi kaka-opera lang nila. So, sinasabihan namin sila, by all means, go ahead with the vaccination. Yun lang po.
Maraming salamat. And Dr. Paloyo?
Yes, sir. So I think may dalawa, sir, na medyo weird. No? Yung una, siyempre yung mga nakikita kong pasyente kasi, sir, mga nagdadialysis, di ba? So, minsan, sasabihin nila sa akin, pag tinatanong ko kasi, sir, yung vaccine status nila, tatanungin ko, bakunado na ba kayo o may booster na kayo? Sasabihin, yung iba sabihin, wala pa ho, Doc. Bakit? Kasi yun, yung kasama ko sa dialysis, nung na-booster, namatay pagkatapos. So na-associate nila yung pagkaroon ng vaccine. Siyempre alam naman natin na yung, of course, nagda-dialysis has a higher chance of, mortality and everything. And na-associate nila yung pagkakaroon ng booster o extra o yung bakuna with them dying. So medyo ang hirap i-dispel ba yung ganong notion sa mga pasyente. Lalo na mga nagda-dialysis, sir. Ano yun, di ba? Isang barangay yun Kung ano yung sabihin ng kapitbahay na nagda-dialysis, yun na yung paniniwalaan ng katabi niya, di ba? Pangalawa, medyo weird lang, sir, kasi may mga, may siguro isa, dalawa na pasyente na post-COVID, no? Post-COVID, post-surgery, tapos tatanungin nila, pag sa follow-up sa clinic, sasabihin nila, Doc, nagkaroon ako ng COVID. Kailan ho ba ako pwede maging intimate dun sa asawa ko? How soon? So, mahirap sa... Nung una, hindi ko alam kung ano yung sasagutin ko. Kasi hindi ko alam kung paano ko sasagutin. Dahil hindi ko naman alam kung kailan pa yung, yung incubation period, etc. So, yun lang, sir.
Ano yun, no? Dr. Paloyo, yan ang Guason Hall rated R question. Diba? Toxic. Okay, balik tayo sa GP question. General patronage to. Another question for all our 4 speakers. Yung question po ay, dahil po naging prominente ang role ng telemedicine sa healthcare system natin since the pandemic, and of course, especially from our facilities and hospitals, ano po yung mga challenges that na-encounter po dun sa shift? And ano po yung parang mga recommendations tungkol dun sa pag-address po dun? So mga ano po to? Questions on telemedicine adjustments. Yun na lang po uling ganong cycle. Dr. Loyola, and then Dr. Magnaye, Dr. Flor Cruz, and then Dr. Paloyo. Dr. Loyola, sir.
Well, in terms sa internal medicine, ang talagang naging mahirap is the lack of physical examination. Okay? Of course, remotely you cannot do that. No? The best that you can do is to take an accurate history and do inspection. But as far as auscultation and palpation is concerned, you cannot do that. So you have to rely on what your patients tell you, and you have to ask probing questions. No? Like halimbawa, nagsususpect ka ng pneumonia, then nagtatanungin mo na lang, pag umubo po ba, humahalak? May plema po ba na lumalabas pag umuubo? So those things became difficult, no? Because you cannot do a full physical examination. So you really had to rely on an accurate history and what you can see over a video call, and what you can hear. If you're familiar enough with your patients, then you can hear any changes in their voice, any changes in their expression, or any changes in their color, no? During a video visit. So at least you can do that. It became doubly difficult among patients who are not known to you. No? So you really have nothing to go on. You really have no personal knowledge of the patient, and you really just have what they are telling you over the internet or over a voice call to rely on regarding your diagnosis. So you really have to ensure that you get an accurate history, and you have to make sure that your patient know of the limitation of a virtual consult. That there may that diagnosis might not be as accurate as you would have wanted if you were on a face-to-face visit. But you try to do what you can. Particularly for patients with pulmonary symptoms, you really prioritize them to have online consults rather than face-to-face consults. So to protect yourself as well. So yeah, you have to rely heavily on history and what the other members of the family can observe with a patient. Yeah.
Ayan. Okay.
Sir, I'll take my cue on that. Thank you, Aldrin. Aldrin is my
Dr.
classmate,
Magnaye?
sir. Kaklase ko si Aldrin Loyola, sir, o diba? Hello, Dr. Loyola.
Hi,
Taking on that.
Reunion.
Oo nga, sir. Oo nga eh. Talagang,
Silver Jubilarians kami this year.
Yes,
Yes, sir.
class 90s. Yes, class
97.
97. Class 97.
yes, sir. Kaya kami nag-yes, sir, sa GSS. Kasi jubilarian. Kasi celebrating batch kami. Anyway, taking on that, Aldrin is really very, very, sir, no, candid and sincere about these teleconsults. Ang hirap-hirap po talaga. And yes, we do rely in otolaryngology as well on a very good history and physical exam, no? Sa amin, dito sa Davao City, dito sa Icons, hindi kami masyadong nag-telemedicine. In fact, very, very, very limited if at all, no? However, you would really note that patients are truly smart kasi sa ENT, nagkakaroon ho sila ng kanilang modification paano pipicturan yung mga sarili nila, no? So marunong ho talaga yung pasyenteng magpicture ng kanilang bibig, no? They're able to take a good photo of their tonsils, of their nose, and in fact, they were also, itong mga pasyenteng to, naturuan din po kami na naglalagay po sila ng endoscopy, yung nabibili po nila sa Shopee. Pinapasok nila yung telescope sa tenga, so nakikita namin yung kanilang eardrum. So, patients are truly very smart. So, through the pandemic, marami ho rin kaming natutunan sa pasyente. And as to the transition to face-to-face, sa amin, sa Icons, hindi masyadong drastic yung transition kasi kahit nung pandemic, araw-araw ho kaming bukas, no? We never really closed doors. The transition was smooth and hindi ho kami nahirapan as to be able to shift from telemedicine to face-to-face, no? Up to today, we still do our PPE. We're not very confident that we're not into our PPEs, no? Hindi, medyo level up ng konti ang otolaryngology sa PPE. Talaga, sir, very mindful po kami dyan. Thank you.
Yeah, thank you very much, Dr. Magnaye. Dr. Flor Cruz?
Sir, sa ophthalmology, very limited talaga yung telemedicine, no? Hanggang kuliti lang po siya. So, pero I think ang magandang use ng telemedicine sa ophthalmology is yung follow-up ng patients, no? Yung mga cataract patients namin na naoperahan na, usually pababalikin namin day 1 yan, and then a week, then after a month, no, for the refraction. Pwede kasing ma-skip yung iba dun eh, no? Kung makausap namin sila through tele-ophthalmology, kung okay yung vision nila, tutuloy lang nila yung gamot. Pwedeng hindi na kami magkita. No? Tuloy na lang yung gamot, hindi lumabo yung mata, infection lang naman, maitawid namin yung first week, maitawid lang namin na walang infection, malaking bagay na yon. So kung nagkausap kami through telemedicine, mababawasan yung clinic visits nila. So mababawasan din yung chance na magkahawahan during these times. Yun lang po.
Okay, thank you very much, Dr. Flor Cruz and Dr. Paloyo.
Yeah. So sa surgery naman, sir, parang pareho rin kami sa kay Dr. Loyola, no? Limited talaga kami sa physical exam. We rely heavily, sir, sa physical exam, di ba? Lalo na pagka surgical abdomen. So again, limited talaga. So ako ang ginagawa ko, one way of sort of parang mapag-bypass yung ganung problema, kasi meron naman kami mga surgical resident or kunyari hospitalist na on call, di ba, na nasa ER, na naka full PPE and everything. So ang ginagawa ko, lalo na kasi siyempre surgical abdomen, I mean yun talaga yung priority, no? Kailangan mo talaga operahan. So ang gagawin ko, I will ask the resident to, sige, pindutin mo yung tiyan. Tapos iharap mo sa akin yung mukha ng pasyente pagka pinipindot mo na. Tapos more or less magi-gauge ko kung may tenderness ba o wala, di ba, sa area na yon. So sa ganong pamamaraan, meron akong konting gauge kung surgical ba ito o hindi. I guess yun lang siguro yung isang way para to malaman namin kung surgical abdomen o hindi. Yun lang, sir.
Grabe, no? Si Dr. Paloyo, yan ang nagpapatunay na Dr. Paloyo, pag gusto, may paraan di ba?
Siyempre, pag kailangan ng operahan, kailangan makita.
Di ba? Pag kailangan mong hanapan talaga ng paraan Okay, salamat. Yung isa pong question para sa 4 speakers ay based po dun sa as early as the middle of 2020, naglalabasan na po yung researches ng WHO regarding the disruption of regular services because of the COVID pandemic for both the community and hospital settings. So yung isa pong tanong, parang gusto pong ma-explore ang thoughts nyong apat dun sa approach na siyempre wag naman po sanang mangyari uli, pero if a similar thing happens, your thoughts on the construction na talaga of a, let's say, ang pangalan naman, kunyari, VIDCO, di ba? Magka-VIDCO pandemic. Ano yung thoughts nyo on just creating a new structure na siya yung VIDCO referral hospital instead of converting an existing hospital? Yun. Ano po yung thoughts nyo doon? I think some countries were able to do that. Yun. Ganun na lang po ulit. Dr. Loyola, Dr. Magnayo, Dr. Flor Cruz, and Dr. Paloyo.
It would have been ideal, no, if we can actually build a particular center specific for a particular disease entity or a pandemic. But the problem is that we are an archipelago. The Philippines is an archipelago. Where will you place that? Okay? And you have patients from Apari to Holo. So you really have to decentralize your institution, if ever. So such that at least one in every region. And that's going to be very costly, and that's going to be very, not only very costly, but that's going to take a lot of time. No? And we may not be ready, we may not be financially capable to do that, no, our country. So what I would like to see is that we should have assigned a medical center in a particular province as the referral center and kept the other medical centers open for the other services. No? Because even if there's a pandemic, the other diseases are not resting. No? Meron pa ring hypertension, meron pa ring diabetes, marami pa ring cancers, marami pa ring kailangan ng surgery. So we cannot suspend services for all disease entities to prioritize one. Okay? So we can probably assign 1 or 2 hospitals per province, and then keep the services of the other medical centers open for everyone. Okay? The other thing is that if we need isolation facilities and we don't have tourists and we don't have and our hotels are our hotels need businesses. then we can probably convert these hotels into isolation facilities. May sariling kwarto yung pasyente, may sarili siyang CR. Okay? And I think the hotel businesses will appreciate that, no? Kasi wala naman silang ibang clients. So kung mild lang, baka pwede nating i-convert yung iba nating tourist facilities into isolation areas, isolation centers, and just perhaps assign medical practitioners in these areas, physicians, nurses, so that those people can have someone to look after them. We probably don't need to build the new infrastructures because there are existing infrastructures. We just have to think of ways to convert existing infrastructures into something that is serviceable to everyone, no? And will also take care of the patients suffering from the pandemic.
Okay, thank you very much, Dr. Loyola. So, Dr. Magnayan, Dr. Flor Cruz, and then Dr. Poloyo.
Sir, siguro ang sagot dyan namin, kasi we're really in a sweet spot. I mean, we're really lucky. We are, wala kami sa NCR. No? We're really lucky. We're not as huge as PGH. And meron po kaming room for a possibility of such infrastructure. Kasi nga, yun pong tinatawag na Southern Philippines Medical Center, it's located in Davao City, no? Meron pong regional center, may regional medical center po ang Mindanao, ang Davao, not Mindanao, ang Region 11. Ito po 1.5 hours away, no? From 1.5 hours away from the city. So, kung infrastructure man lang, I think it will be perhaps possible in Region 11 to do that. Kasi nga, may space, meron kasi siyang advantage pag may center na ganun for VIDCO. May advantage talaga. Siyempre, walang ospital, lalo na ang SPMC. Ayaw niya nang maging one COVID center siya ulit. Ayaw niyang maging one VIDCO center the second time around. Kasi it really took a lot of Southern Philippines Medical Center, no? Kahit na laudable yung naging response niya to Region 11, no? Ang laki-laki ng tulong ng SPMC sa aming lahat sa private hospitals ng Davao. Pero tama po, palagay ko may room ho talaga na magkaroon po ng infrastructure in Region 11 for a VIDCO centers. I think so. Thank you.
Okay. Thank you very much, contestant number 22. Dr. Flor Cruz.
Sir, well, ophthalmologist lang po ako. Pero may alam ako nakapagpagawa ng COVID center ngayon. Wala pa tayong VIDCO. Si Dr. Ophthalmologist po yung CEO sa TMC Stout. And I think Dr. Cesar Espiritu, yung leadership niya, they were able to build a COVID center detached from the hospital sa South po, sa Laguna. And yung pag-design nun, nagawa din niya, yun nga, yung peculiarities ng COVID, I think naayos din nila yung design nung hospital. I think may mga donations din from private sectors, no? Yun, hindi ko po alam yung details kasi nakwento lang niya habang naglalaro kami ng golf. Yan.
Okay, maraming salamat. And Dr. Poloyo?
Yeah. So, sir, again, I'd have to agree with Dr. Loyola. So, kasi nga, medyo parang ang labo na isang one COVID center for the whole country. Parang ganon. Kasi nga, geographically, ang lalayo natin. So, maybe identify siguro 1-2 areas in Luzon, 1 in Davao, 1 in Cebu, parang ganon. Diba? And again, ito na naman tayo, para nangangapit bahay na naman tayo, kung ano yung nakita natin sa kapitbahay natin na supposedly working, gagayahin na naman natin dito. ang sa akin lang, I guess we should always think na something that should be tailored to our needs, not necessarily, what's working for the other countries should automatically work for us. Hindi dapat ganon. So I guess, tingnan natin yung sarili natin. Maaring maganda nga yung idea nila, but again, it doesn't apply to us. Yun lang, sir.
At siguro with that, yung binanggit ni Dr. Paloyo, we will be ending this session. No? Ang galing nun. Iwas talaga tayo dyan, Dr. Paloyo. Yung tinatawag nila sa social sciences na angat patong. Yung, di ba? Porque, kunyari, IQ test sa Canada, may picture doon ng ice hockey puck, di ba? Tatanungin mo sa isang bata sa Masbate, lalabas bobo yung Pinoy. So that's an excellent ending to our session. Thank you very much for that point, Dr. Paloyo. So maraming salamat, Dr. Flor Cruz. The best talaga yung golf, no? Pwede mag-meeting dyan, di ba? Yung meeting sa meeting, meeting-meetingan lang yan, tunay na meeting sa ganyan. So thank you very much, Dr. Loyola, Dr. Magnaye, Dr. Flor Cruz, and Dr. Paloyo. Maraming salamat po at isang magandang hapon po sa ating lahat.
Thank you, Dr. Loyola, Dr. Magnaye, Dr. Flor Cruz, and Dr. Paloyo for the very productive session. The College of Medicine of the University of the Philippines, Manila, and its Postgraduate Institute of Medicine present with gratitude this certificate of appreciation for your invaluable contribution as speakers. Thank you. That has been our session number 2. Thank you to our speakers and moderator. Our day 2 doesn't stop there, so stay with us as we enter our third session geared towards telemedicine. From actual practice to current guidelines, our notable speakers from the National Telehealth Center, Department of Surgery, and Medical Informatics Unit will be walking us through the Philippine landscape of telehealth, its role during crisis, and the current guidelines we need to know in the setup of telemedicine in private practice. To share with you valuable and relevant information now more than ever, let us meet our dear speakers, Dr. Iris Isiptan, Dr. Esther Sagil, and Dr. Portia Fernandez Marcelo. For our Q&A session, Dr. Benjamin Sablan Jr. will also be present as our moderator. Dr. Iris Isiptan is the Chief of the Medical Informatics Unit of UP Manila, the Chief of the UP Manila Interactive Learning Center, and the UP System Gawad Pangulo Awardee for Progressive Teaching and Learning.
Good afternoon. Here's my call to action moving forward with telemedicine in the post-pandemic scenario. During the lockdown, telemedicine became the only way for patients to see their physicians. This was not an ideal situation given the limitations of a virtual physical exam, which often precluded a thorough clinical assessment and made it more difficult to reach good therapeutic decisions. Even more risky was when the pandemic forced physicians to see patients needing emergency care via telemedicine. Choppy connections and unfamiliar interfaces also proved a hindrance to good communication and developing good therapeutic relationships, as some of us found the adjustment from bedside to webside manners daunting. It is no longer an either-or situation, in-person or telemedicine. We are no longer on lockdown. Moving forward, we should be establishing a hybrid approach. Lay down protocols where in-person visits can be interspersed with telemedicine, be it via audio, video, store and forward of clinical data, or remote monitoring. Stop using telemedicine in situations where it will fall short of standards and patient safety because we have options now. As we move to hybrid approaches, we need implementation research. We need to know what works for whom, when, and where. Invest in a telemedicine platform. Do not use social media platforms. In 2020, when we made the UP Medical Informatics Unit telemedicine guidance documents, we noted that the U.S. Department of Health and Human Services Office for Civil Rights released a notice allowing healthcare providers to use social media platforms like Apple FaceTime, Facebook Messenger video chat, Google Hangouts, Viber, and Skype to provide telehealth during the COVID-19 pandemic despite previous Health Insurance Portability and Accountability Act or HIPAA restriction. However, note that the Philippines is not covered by HIPAA but by the Data Privacy Act of 2012. Such relaxation of the HIPAA rule may not necessarily apply locally. During the lockdown, Facebook Messenger and Viber, I was told, were the easiest ways to communicate with the patients. Given that situation, my advice was to include in the consent form the risks to privacy and confidentiality. To protect the physician, the informed consent documents that the patient accepts the risks of using these platforms. But again, we are no longer on lockdown. We must consider more than just convenience. I've been told that the learning curve for patients for telemedicine platforms is steep. It doesn't have to be. I use a browser-based telemedicine platform that does not require the patient to download an app or install anything. Patient selection is key in keeping the teleconsultation safe for all. If the patient is not tech-savvy enough to log into a telemedicine platform, then that patient should be seen in person. We must be careful not to entrench pandemic adaptations into institutional practice. For the past 2 years, I presented at many conferences on the telemedicine workflow we recommended in the UP Medical Informatics Unit telemedicine guidance. What to do before, during, and after the televisit. 3 steps each, so 9 steps in total. What to do before: set up, select the patient, secure an informed consent. During the visit, verify identity, conduct the teleconsultation, document the visit. After the teleconsultation, send a visit summary, send prescription or lab requests, elicit feedback. I was told it was too complicated. I realized that it's because it's physician-centric. Other health workers in the in-person process lost their roles. How about nurses, dietitians, pharmacists? What are their roles in telemedicine? Nurses can help triage the patients for teleconsultation. Pharmacists can teach the patients the use of medical devices and do medication reconciliation. There can be team televisits where dietitians and other consulting specialists can see the patient together. In my private practice, my secretary schedules the appointments, checks if the pre-visit requirements are complete. My secretary is also on standby to call the patient on the phone to troubleshoot and guide if the patient has technical problems during the teleconsult. After the televisit, she confirms with the patients if they receive their visit summaries, prescriptions, and lab requests. To realize the benefits of telemedicine, we need to streamline the workflow. I have a health informatics graduate student now, for example, whose thesis is on the use of photos taken by patients as an adjunct to enhance teleconsultation for joint disorders. In my observation, the bulk of telemedicine use during the pandemic was synchronous, either video or audio. Video was hampered by poor Wi-Fi connectivity, while audio was less than ideal in certain situations because the physician can neither touch nor see the patient. Internet connectivity is mostly out of our hands, though we should continue to lobby for it. But in the meantime, we also need audio telemedicine protocols. Anecdotally, I'm able to do audio-only teleconsultations on my telemedicine platform for routine diabetes follow-ups. I've also tried store and forward. Patients email me blood sugar and blood pressure monitoring values, follow-up lab tests, for example, TSH, FBS, or HbA1c, in between visits, where I just need to see if dose titration is needed. How about phone calls? There's a standardized 23-item questionnaire for telephone follow-up of heart failure, which only takes a median duration of 6 minutes to administer. If the patient scores higher than 9, the patient is sent to the hospital or triage for urgent follow-up within the week. If the score is 4 to 8, follow-up after 2 weeks. And if the score was less than 4, follow-up after 1 month. This questionnaire developed during the pandemic has eventually been validated for safety. And it only used the phone. So how about SMS? There's the Tasmin H4 study, a 2018 randomized controlled trial with 3 arms: self-monitoring BP only, self-monitoring with telemonitoring, and versus usual care, where BP was only checked at the clinic visits. Participants in the telemonitoring group sent their BP readings via SMS. They were alerted to contact the clinic for very low or very high readings, reminded if not enough readings were sent, and asked to contact the clinic if the BP was above target. Attending clinicians viewed the web interface, which automatically calculated the mean blood pressure per week, highlighted very high or very low readings, and presented a graphical display of BP measurements. This is the first trial in primary care of antihypertensive titration using self-monitored blood pressure with or without telemonitoring to show a benefit in BP reduction after 12 months. Additional telemedicine benefit was seen because after 6 months, the blood pressure was lower in the telemonitoring group. And it did not require too many resources to carry out. So yes, let us consider low or no bandwidth options. Lastly, in the setting of universal healthcare, we can also enhance service delivery networks with telemedicine. Much of the local pandemic use of telemedicine I have seen has been patient to physician. But telemedicine also includes primary care physician to specialist, nurse, barangay health worker, midwife to primary care physician modes, which we should explore further. In a study of 2 hospitals in Brazil, a telemedicine service was set up between a remote hospital and a tertiary hospital. As specialists provided support to the remote hospital, it influenced making a definitive diagnosis in only 7%, but it contributed to clinical management in 93%. Most impressive was thrombolytic therapy, where it was carried out in the remote hospital for 11% of stroke cases, where it has never been done before in that hospital. There was also a 25% reduction in hospital transfer for neurologic evaluation. As with the teleconsultation and a clinical and radiologic algorithm, alert trauma patients, head trauma patients can, for example, be selectively hospitalized in a hospital without neurosurgical service because it wasn't required. So the telemedicine sepsis protocol was also adopted, and this led to a 30% reduction in mortality for severe sepsis in the remote hospital. So this is interesting data. Currently, I have another health informatics graduate student whose thesis is on the use of static images in telepathology for second opinion readings. So as service delivery networks are instituted with universal healthcare, we need to explore how telemedicine pathways can also enhance them. Thank you.
Dr. Esther Sagel is the president of the Philippine Surgical Infection Society, a past president of the Philippine Society of Pediatric Surgeons, and the president of the Association of Women Surgeons of the Philippines.
Good day. I'm Dr. Esther Sagil. I'm the chair of the Department of Outpatient Services, and I was asked to speak about the evolution of telemedicine in the Philippine General Hospital. Just for the record, I'm also the chair of the Telemedicine Committee of PGH. So before March 20, this was the common sight outside of the OPD. Even at dawn, patients would be queuing outside the building or even in Padre Faura seeking medical attention in PGH. Our usual daily consultations would number about 2,000, and this was the melee of the crowd that was in the lobby around 7 a.m. So we do serve up to 600,000 patients annually, and we clocked an all-time high of 56,000 patients in February 2020. So obviously we're perpetually congested and there is a prolonged waiting time for consults. Then COVID came. Can you remember March 17? ECQ became the byline, and we were all asked to go on strict home quarantine for all households. The term APOR or APOR came out. And it was exactly the same in the PGH OPD. We were a ghost town. But people needed to have someone to talk to with regards to their medical needs. And of course, also because of COVID. So UP Manila came up with a COVID-19 hotline in partnership with PLDT. And that was what Bayanihan na 155-200 was. It was supposed to be something about donating to, or how to help with the COVID efforts or how to donate to COVID. But it came out that 80% of the calls were about patients' access to medical care. So our interns, our clerks, our residents were staying here in the nurses' home, which is converted to the hotline center. And most of the patients were asking how they could continue their treatment here in PGH. But the Department of Health came out with a memo. Use telemedicine first for consultation during this pandemic. And we had to adapt. Everybody, all departments, divisions were in a mad scramble to reconnect with the patients. They created Facebook pages. They put out cell phone numbers or hotlines for departments and divisions. Some fellows and residents even gave their personal numbers to patients just so they could connect. And of course, we took a look at the guidelines or guidance documents that came from the Medical Informatics Unit, the DOH, and the Philippine Medical Association. These were circulated, and most were actually in a quandary as to how to really comply with the guidelines. The cancer patients were among the first that had to resume their treatment. They were in limbo as to how to continue chemotherapy, how to proceed with the surgery. So the CI, Pedia Hemo Onco Service, came up with this poster. And notice the ubiquitous F. There's always a Facebook page there. Same is true with the surgical clinics, colorectal, GS1, 2, and 3, urology. Ophthalmology was very innovative. Remember, one of the early mortalities, the whistleblower of the COVID pandemic, was actually an ophthalmologist. So they did come up with Tagalog in the vernacular announcements. And lo and behold, you're getting calls from everywhere in the Philippines, including and also abroad. There were calls from New York, Saudi Arabia, Hong Kong, just showing that Filipinos were not the only ones alone in not getting medical help. Even those abroad were not getting the medical help that they needed. So it was so funny that it also had a Visayan translation. Then we came out with the medical department. They had follow-ups, diabetes patients, lupus patients, rehab patients. They were lost. So these divisions and departments came out with their own hotlines, cell phone numbers, Facebook pages, just so they could again connect with their patients. But at this time, all were in calls, messenger calls, fiber calls. There was no formal e-medicine, telemedicine format by which these people could connect with their doctors. So it was really a challenge. First, Facebook Messenger, Viber, they're not secure. We tried putting out the medical type of communication, like, Serious MD, DocsMe, but apparently our demography of patients could not adapt to these platforms. Worse, usually they had poor or no internet connections, and I found out that 80% of the calls coming from the Department of Medicine were audio only, which actually is not the recommended type of telemedicine or teleconsultation. Many patients also had no personal gadgets and were just borrowing gadgets of their relatives or neighbors. They were also piggybacking with email. So if we were going to email the patient, we'd find out that another person was going to answer. It was not the patient himself, because he did not know how to use email. So our concerns with privacy, data privacy, also came into play. From the PGH side, we had limited gadgets. We had no gadgets here in OPD. So it was a bring your own device thing. There were also limited cell phones that were for public usage, whereas you have a phone, but there's no load. So we had to look for donors for the load. Wi-Fi was unstable, as is our line service. We realized that there was really more time needed for virtual consultation, for you to establish connection, to lay the groundwork for the consultation. It was longer. It took longer. So we could not service the same number of patients that we used to do pre-pandemic. Our issues for privacy came into play. We were also having difficulty with documentation of the encounter. So yes, there was a call. It could be recorded, but how could we now incorporate these encounters in the medical charts? Really, what we realized was we were ill-prepared for the digital transformation. But because of a collaboration with the UP Industrial Engineering Department, for which we are very grateful, in June 1, 2021, we came out with the OCRA, or the Online Consultation Request and Appointment System. So initially, this was for existing patients, but evolved into even for new patients. But it was an organized way of establishing contact through an online platform with the doctors of PGH. And this is how it looked. Because there was now an OCRA, we had to put a stop to the Facebook Messenger calls or the direct calls and make it pass through a process through the OCRA so that we could record the patients and consultations and encounters with the medical staff. So you will notice that from evolving from a Facebook Messenger or telephone number call, it now evolved to a please consult or register yourself with OCRA, and you will be able to get in touch with us. So it was like a formalization or operationalization of our efforts in telemedicine. This was a gradual and difficult transition, but eventually this is now much easier to carry out. But we had, of course, our enablers. Were first, the technocrats, UP Industrial Engineering, of course, our homegrown talents here in UP and PGH, like Dr. Homer Ko, who created the EMR. They continually improved the electronic medical record system and consultation system. In fact, the OCRA, which was created by the engineering, was also made interoperable with our Radish. We, of course, had donors. We could not have set up a hotline without a donor in PLDT. There was expedited procurement of equipment because of a lot of donations that came because of the COVID donations. So we boosted Wi-Fi signals within the OPD and in PGH. Of course, I cannot say thank you enough to the staff, the doctors, trainees and consultants alike. Trainees, because they were intent on continuing training. Everybody was having problems with how they could train if the patients were not here, especially with the surgical specialties. How could they train if no elective surgeries were being done? So while continuing training, how could they continue rendering service? And then, of course, our nursing service, who were all, embroiled in the COVID wards. Even my OPD nurses were being asked to go on duty in the COVID ward because this had to be, a rotation system. They're very supportive. And of course, our administrative personnel. But most of all, really, there was a demand from the patients. A lot of patients asking, pleading for a return of the outpatient department so that they could continue on with their treatment. And I think most of us are already aware how many of our patients had delayed treatment, delayed surgeries because of this pandemic. So we also were able to develop an OPD telemedicine hub. This was made possible through the generosity of the UP Manila Foundation, of course, through our chancellor. But this was a total of it was our conference room in the OPD, but we converted it into a hub. So it contained 21 telemedicine units. Apart from that, there were other units in the other clinics that we also used for telemedicine. So eventually, we were able to create an area in the OPD where we could continue doing telemedicine while we were already starting the face-to-face consultations for some patients. Like, for example, OBGYN, it's rather difficult to do a perineal examination in a telemedicine setup. So there were some services that had to resume face-to-face consultations much earlier. But most of the medical, family medicine, internal medicine, pediatrics were able to do consultations on a telemedicine platform. The Radish is our homegrown EMR, and it really expanded during the COVID pandemic because we had to facilitate paperless documentation in the wards. So it grew and grew until it became applicable to the follow-up of the COVID. Those who were admitted for COVID, they had to be followed up. So up to the outpatient surveillance, the Radish EMR was being used. It allowed seamless generation of paperwork. So apart from clinical abstracts, which are very necessary for the COVID claims of PhilHealth, was able to generate prescriptions for our patients, particularly for those who were in remote areas like Laguna, Cavite, Batangas. They needed to have prescription refills. And because the FDA allowed online prescriptions, we were able to accomplish this using this. Radish was also integrated with our laboratory, MSS, dietary areas. So the full integration helped us give a comprehensive, holistic management of our patients. So it was really improved record keeping for all because everything had to be recorded in this EMR. And as I said earlier, it was melded with OCRA. So if you had consulted in OCRA, your consultation would be recorded in Radish. And this is what we call the PACVET, or the PGH appointment at consultation via telehealth. So what is the future of telemedicine in the new normal? We're already doing face-to-face. In fact, OPD is again crowded, but we are trying to stave the crowding because the pandemic is still not yet considered over. We still have to do our social distancing, and we still want to maintain some modicum of orderliness on what we know as the new normal. We all know that We shouldn't be going back to the old practices where everybody was crowded inside a room. A 6x6 room would have 20 people. That is not anymore acceptable. So because of this, we want to improve the telemedicine infrastructure. And what they mean by improving the infrastructure, we have to put the computers. We have to have good internet connection in the clinics. We have to have printers there for everything. And then we can do both face-to-face and telemedicine in our clinics. And we want to determine the optimum utilization of telemedicine in the consultation process. For example, in most of the guidelines, we read that ideally, the first consult of telemedicine should be a face-to-face consult, and we want that to happen. But more than that, we want, personally, I would prefer that the first consult to establish rapport is a face-to-face consult, and the succeeding ones can be on a virtual level, because at least you have already established a relationship with the patient. Okay. And what is actually the optimum utilization? We've been trying to rack our brains on how we can still use telemedicine in conjunction or as an adjunct to our face-to-face or physical consultation in the OPD. And we saw that surveillance, like for example, post-operative follow-ups of patients you saw at the emergency room, patients who had undergone surgery or were admitted in our wards, but can be evaluated on a virtual platform. Prescription refilling, you just need to check if the patient is okay, is thriving with your prescription, nutritional assessment. And more importantly, we want to give access to specialty care, because we know PGH has a lot of specialty clinics, to remote areas. And this is something that we feel has to be in collaboration with local health centers or regional health units. And we would like to work on that in the context of eventually universal healthcare law. Of course, with telemedicine, we want to also make sure that we adhere to existing applicable and governing laws. So all in all, we know that our adoption of telemedicine was really biglaan, mabilisan, in English, expedited. But now, because we are slowly transitioning into the new normal, we would like to see telemedicine to be practiced in a more nuanced, in a more ideal way, but at the same time, harnessing the strengths, the value of telemedicine, particularly in the grand scale of maldistribution of health workers, of medical care, of doctors. We might be able to grant access to our specialists, to our kababayans who do not have ready access physically, but will be able to reach us in a virtual platform. So thank you very much.
Dr. Portia Fernandez Marcelo has a master's degree in public health from the Johns Hopkins University. She is an Alumni Association Distinguished Alumna Awardee in Public Health Promotion and a professor of the UP College of Medicine.
Oh, yeah. Good afternoon to everybody. Yes, I'm with the Department of Family and Community Medicine as a professor, but I share my my knowledge about telehealth, being part of the National Telehealth Center for about 60 years, ending in 2017. So I did not experience being the telehealth director during the pandemic period. But certainly, I've had several research in telehealth. This is my outline of presentation, and my experience is really telehealth for isolated and geographically disadvantaged communities. And I'd like to share briefly about our experience in telehealth in crisis. Then let me update you about the Philippine telehealth landscape and our readiness, in fact, as we move forward from the emerging from the pandemic. So let me share about this idea about crisis. So crisis is time of intense difficulty, and the term humanitarian crisis among us health professionals should be the one that we are using. So really, it is an event that threatens in terms of health, safety, or well-being of a community or even a larger group of people. And the idea of security as well is brought in when you talk about human emergency. So when we talk about crisis, we should use the term humanitarian crisis, humanitarian emergency instead. Vulnerability should be an allied term for us in the health sector. And to clarify, this is the reduced capacity of individuals to resist or recover from all of these life-threatening hazards. And would like to emphasize that the poor populations are more likely to be more vulnerable to both man-made or natural disasters. And we saw that COVID is really an emerged as a disease, but the Philippines is typically under threat every year, every month, likely to natural disasters. Okay, ayaw mag-move. Okay, I will ask our tech team to present instead. It's not moving, sorry. Thank you. Okay, next slide. Yeah. This article is is a paper that we made, published in 2018, which was actually written way back when we actually implemented telehealth in disaster. So this is made by Dr. Magtubo and colleagues. And what did we find out? Next slide, please. Please recall that in any disaster, there has to be 4 stages. So you have to prevent and mitigate. So you really have to prepare for the emerging disaster. Then certainly we respond. And after the response, we rehabilitate and recover towards the new normal or the better normal. Okay. Next slide, please click. So in the 155 articles that we found related to this topic, only 14 fell within our criteria that it should be English and should cover lower middle income or low income countries. And certainly we affirm that telehealth is in fact not part of any of these countries' disaster risk management plan. And studies showed that telehealth was only part of the response phase. So this was mainly in India, the Philippines, Pakistan. And essentially these countries used mobile technology and satellite communications. India has its own satellite, and in various states of India, they're actually using it for their day-to-day telemedicine systems. And when you talk about telehealth in disasters, it's really funded externally, not by the country. Next slide, please. And when Yolanda hit us in 2013, this was at least 60 trillion pesos in terms of damage. Next slide. So what did we do? Since 2004, the UP National Telehealth Center has reached up to 774 towns across the Philippines and introducing telehealth as a means to improve healthcare system. So Dr. Sagil earlier on is or was a telehealth expert. So for pediatric surgery or surgery in general, Dr. Sudabarius from Batanes to Tawi-Tawi would send her messages and ask about cases that they attend to. Dr. Homer Ko, who developed Radish, the EMR, actually was run the program also before I came in. And he actually addresses cases also for adult medicine. And because we were in touch with several doctors at that time in 2013, there were 400 in our list of municipal doctors and doctors of the barrios across the country, including 136 in Region 8, Samar and Leyte. When Yolanda hit, then all the communications were down. And fortunately, there was some messages coming across such that the WIRIS, that's what we called it, Yolanda Response Information System, with the support of Sahana Foundation. This is an NGO that also responded to the Asian tsunami. We were now able to get in touch with the doctors in the region, in Region 8, and one, communicate this to their family, and that they also sent messages about their needs in their communities. And then daily, we would report to the Department of Health about all of these things. Unfortunately, this is not actually adopted it remains that disaster response and telehealth should actually be part of our agenda. Next slide, please. Okay, so the authors concluded that because we are number one now in the World Risk Index, when we wrote that paper in 2016, if I remember, we were number 3 in the World Risk Index. We have topped it now by this point. So because we are disaster prone, then if we have telemedicine across the country, then the other countries should come to us and learn how to do it properly. Okay, next slide. For Canada, the telemedicine industry improved or grew much more during the COVID pandemic. And Canada actually has been doing telemedicine since 1970s. Telemedicine for their own GIDA, the First Nations, the Indigenous peoples of Canada. And this author would say that up to 5 billion per year is the economic value of telemedicine in terms of time saved, fewer unnecessary emergency care visits and missed appointments, and access to primary care provider. And precisely this is the promise that we want for our country. We actually did a local study, a doctor and an economist, next slide please. And he estimated based on available data that the annual potential value of telemedicine for the health system of 600 poorest municipalities reaches up to 790 million pesos annually. So really, we should lay down this envisioned system where facilities and clinicians are always in touch with their patients. Next slide, please. Yan. I have to review with you that in fact, we campaigned for telehealth way back, and it's interesting to still see that we are not ready for digital transformation, even if the foundations have been laid way back in 2004. And so the UP actually had its first national telehealth service program, or we called that at that point BodyWorks, in 10 areas in the Philippines nationwide. And while Dr. Loyola earlier on mentioned about the proposed House bill, way back in 2010, the director of telehealth at National Telehealth Center, Dr. Alvin Marcelo, actually presented before the Committee on Science and Technology and Engineering of the Congress, precisely because of the value of telehealth and laying down the backbone across the country. It took a pandemic before the administrative orders came about. And to date, there's still no law about e-health and telehealth. 2013 is a milestone because of all the research that we have contributed to the body of evidence. Finally, the National E-Health Steering Committee, it's a national governance body made of all of these national government agencies so that it can set directions how to use digital health or e-health for national development. Next slide. Next slide, please. So indeed, all the research is for 110 million Filipinos who is beset annually with all of these crises or potential crises. Telehealth when we envisioned it, was first intended for the poorest of the poor. And as Dr. Iris noted, telemedicine during the pandemic was really for those who actually in the first place had access. That's the need to even expand what we have. The continuing problems of our country is actually manifested by our being 116th of 191 in terms of human development. So here it factors in economic, education, the business sector or the business climate, and so on. And we are only 59th of 132 in terms of global innovation. So precisely because, so there are a lot of challenges. And indeed, when we talk about implementing telemedicine, it has to reach communities nationwide, so that the equity value or the inclusiveness value of innovations must be underscored likewise. Next slide, please. Okay, this is precisely the impetus for the Universal Healthcare Law, and in this law enshrined into policy the principles of universality, equity, and accountability, and individual responsibility, but social solidarity. It also tells us that it will not be perfect now, but we have to keep on moving towards universal healthcare. Next slide. And in this universal healthcare, it will ensure that every Juan and Juana is actually assigned a primary care physician, and that facility that primary care physician belongs to has its own partners in terms of ancillary services. And in case patients need specialists, there are formal relationships with hospitals. And when the general hospitals need to refer this patient, there should be an apex hospital. PGH is an apex hospital, and therefore it has to form relationships where the primary care physicians and municipalities and facilities are in, and the system will have to move towards this envisioned system, which is actually present in a lot of countries already. So we're lagging behind in terms of that. Next slide. So that is the promise. And in fact, this system is envisioned to have an integrated health information system, all facilities linked by telehealth. But we also have to be cognizant that we are both a public and a private healthcare system, and that the private sector is mainly active in the hospital care, and government caters mainly at primary care and first-line facilities all over the country. In terms of beds, hospital beds, the private sector actually holds more of all of these. That's why the impetus for us working together is actually greater. Next slide, please. Okay, so this research, which we did for the DOH and the DOST-PCH-RD, asked me to put together a model to which government can implement telehealth in a universal healthcare vision and the roadmap in implementing that. And what did we find? What did we put together? Next slide, please. There should be telehealth or telemedicine systems that are intended for improving professional competence anywhere you are and whatever type of health professional you might be. So again, telehealth services for professional support. And there should be public and patient education telehealth services. So the outcome of which is to improve health literacy. So they should be able to also navigate the health system as they enter the health system here. So in the middle of this telehealth watawat, it looks like the Philippine flag. This is where teleconsultation actually happens, and the patient-doctor relationship is established in that primary care provider system. So telecare can actually happen anytime. that primary care facility is linked to a pharmacy. So there is telepharmacy in that system. You enter the bigger healthcare provider network. When you start the teletriage process and transfer care from primary to the hospitals into the healthcare provider network. Below is the degree of regulation by government. And you can see as care is actually formalized, the degree of regulation must increase precisely because of our accountability for patient safety and certainly to ensure better patient outcomes. Okay, next slide, please. What did we find out? Actually, a lot of the innovations of the National Telehealth Center only centered into this one, into teleconsultation. And we only had 2 systems that we modeled where telehealth in a healthcare provider network can actually happen. And we've had a lot of professional support types of telehealth systems. Next slide, please. Amidst the COVID pandemic, so Dr. S, the COVID hotline, majority of the patients were here, but as the telemedicine systems came to fore, you were here. While it's not a primary care provider network because it's clinic to clinic, it turned out to be like that rather than into a service delivery network. Okay. And there were several patient webinars and professional webinars from all the disciplines within the UP Manila, the Health Sciences Center. Next slide. What is prominent is that many, like the city of Taguig, set up its own telemedicine system, Navotas, and the DOH also vetted several emerging telemedicine companies in order to support the telemedicine that they put together in order to help patients who were seeking care at that time. And in fact, we counted a 206% increase in telehealth providers. When we began the research, there were only around 40, and by 2021, there were 95 already. Next slide, please. And this was the types of telehealth services. And again, it was only what the UP put together as models of telehealth in healthcare provider networks. Next slide, please. So this is what we did in Quezon City. So the Quezon City, all the 79 Quezon City health centers had an electronic medical record developed by the UP Manila, the CHITS. And we connected that to the lying-in clinic. So there is a mag-ina tele-referral system such that when difficult cases are also encountered, the lying-ins would be able to refer their patients to their hospitals at that point. And the Quezon City had a single database or patient registry. So the outcomes of while we started the project or the research way back in 2011, we followed a cohort of 517 mothers with difficult pregnancies, and we are happy to say that all of these pregnant mothers delivered safely, and the telereferral system actually demonstrated that an electronic service delivery network can actually happen. Next slide. Yes. And this is another research that we did. It's Hearing for Life. So Dr. Charlotte Chong, our Dean of the College of Medicine, led this project. So what we did here in terms of newborn hearing screening, so the primary care facilities, the rural health units of Iloilo were linked to the ear diagnostic facility and for newborn hearing screening. And out of the 420 patients that we telereferred, 7 were actually confirmed to have bilateral deafness. So it can happen. And what actually helped? Next slide. Yeah. What can happen? What helped? Governance. So the heads of agencies of all of these facilities, we took time in establishing all of these standards-based interoperable e-health platforms, citywide geographic institution-based healthcare provider that were organized. So there were memorandum of agreements, and because we were using, because of that, there was seamless flow of information between primary care and the more complex health facilities. And another important component is a health professional education and change management in all of these institutions. Okay. Next slide. Yeah. So lessons which are consistent with what the Pan American Health Office and the European Regional Health Office, the WHOs of those regions, or is that partial interventions are not sufficient. And therefore, they have to come in a package. And the processes are difficult and complex, and they require systemic changes. So Dr. Esther Sagil, as head of the OPD and the entire PGH system, will have to sit with a lot of local governments. We cannot see 600,000 patients, ranging from primary care to tertiary care and even super tertiary care for the whole time. We have to change. And there definitely that commitment should go beyond, whoever is in position, including the local governments. And there are opportunities actually right now, and the universal healthcare investments must be taken advantage of. And it's exciting that 641 of you, I am sure you are all over the country. You have to be friends and really go into partnership with your own local communities. Next slide. But is the Philippines actually ready for telehealth and universal healthcare? What did we find out? Okay, next slide. And actually, we're still at the developing and building up stage, so of a 3-stage e-health environment. That means many things yet have to be set up, and it's not only the ICT environment that we have to talk about. So next slide, please. So part of this idea of this environmental scan is actually the infrastructure, and let's zero in on internet. This paper is an internet inclusivity, and in terms of the Internet Inclusive Index, we are 19th of 26 countries, 63rd of 100 countries in terms of availability, affordability, and quality of internet. Look, the Philippines pays, the Filipinos with good internet pays 1,155 monthly, while our counterparts in South Korea and Japan pays 20 pesos or 12 pesos. So that's 100 times more expensive for telehealth. And of course, somebody's getting rich, or some bodies are getting rich with the monopoly or duopoly. So that cannot actually happen for forever. So that has to change. And change did not come. Okay, next slide, please. What are the problem areas at this point? So using a traffic light, a lot of oranges, no? So high-speed data connectivity is a problem. While there is electricity in general, there remains 2.3 million families without electricity. So it has to be part of the development agenda. We just don't talk about telehealth and doing it. And this is the call for all of us. As doctors, we have a special position in the community. We have to campaign collectively with our own local governments, regional governments, and so on. For the health sector, this has yet to be set up, that health information exchange, this national data warehouse center, which PhilHealth and DOH have already initiated, but it's still orange because it's still not there and functional at this point. Next slide. So marami pa pong dapat gawin, sa totoo lang. And following the WHO International Telecoms Union, there's actually a menu of things to do, and we echo all of these. And what is really most important is governance. We initiated already that movement towards multi-sectoral governance. Certainly, elections, the changes in leadership, and when you talk about election and leadership, it's both at the national and local. So, parang the momentum that we are in, we keep on pausing, if you may, no, as the leadership changes. So, well, persistence remains to be key. Okay, next slide. I put this back because this is our almost near future. No, there are 58 provinces and cities that are putting this together, and the DOH, aside from when I say DOH, the local governments and all of us, as we tried to respond to as we responded to COVID, a lot of the foundations for this universal healthcare has been actually being put in place. They're not perfect, and that's why the call for us to come together. Okay, my final slide. Next, please. Yeah. So for us doctors, and in fact, we are now tele-doctors, so telemedicine, medical practitioners. I have 3 things which I learned again, which I adopt from the principles of health data governance. So the first thing we really have to do is to protect our patients whenever we're doing telemedicine. That's what we first swore as we became doctors with the Hippocratic Oath, no? Primum non nocere. So we really have to learn how to do telehealth properly. And Dr. Iris underscored, no? Parang we just don't delve into all of those things. Protocols are missing, and that's what we found out. The Pediatric Society actually put something together, but I think the first one who put together guidelines for telemedicine is actually PCR, the Philippine College of Radiologists. So way back, I think in 2014 was their first draft. So there has to be more, and it starts with conversations among you and your colleagues in your community, and it has to be shared so that it can be validated by many and affirmed to be a safe process of doing telehealth. And this is also the request and call of our own Dr. S for PGH. So I suppose all institutions have to go through that. So increasing the health value of telemedicine, this forums should be more. I'm sure a lot of people have been doing telemedicine. And again, Iris elegantly put it, there has to be more implementation research to demonstrate that, in fact, telehealth and all its investments are actually do redound to better care. And finally, promote equity. So it's not only for our patients. You are part of your bigger community. So if telemedicine works for you and your patients, you can spend a little more time to make sure that your community and those who are in the laylayan can actually be reached further. And I think the best way is really to contribute to the conversation how that universal healthcare, or for those of us who are community medicine practitioners, health for all can actually be achieved, and it can. So we look forward to seeing you again, and because mahaba pa po ang health for all natin. Thank you.
Thank you very much.
In this session chaired by Dr. Maria Angelica Tomas and co-chaired by Dr. Ces Alinea, join us as we take a closer look at telemedicine in a local context and its role in public hospitals and private practice.
Thank you very much, Dr. Iris Isiptan, Dr. S. Sagil, Dr. Portia Marcelo for presenting telemedicine. And I think the presentation indeed was very, very informative because Dr. Iris presented telemedicine in a private or clinical setting. Dr. S highlighted telemedicine in the hospital or a service delivery institution. And Dr. Portia Marcelo, very interesting, is telemedicine in a public health perspective as well as in research. So as your moderator this afternoon, I'm going to combine and organize the Q&A because there's a very interesting question in the Q&A box. The question is really on regarding e-health. Is there an existing or any proposal for a centralized data bank or a central computer which contains information of the patient profile and chart, which can be used by any clinic or hospital or nationwide? And I think this is very, very important question, especially for those who are going to start their practice. So maybe let's start with the clinic first. Dr. Iris Tan, would you like to comment?
Okay. So I'm sure that Ma'am Portia is also aware that under the Universal Healthcare Act, ours also supposed to have a national health data repository. So I don't know if that is what is meant by the commenter asking if there's going to be a central repository of data. So even before, they were already planning at the Department of Health for Philippine Health Information Exchange, and that has progressed. And in the UHC law now, that is being called as the National Health Data Repository. But I'm wondering if the question also has to do with having one central electronic health record or EMR, because that always comes up when I'm at these discussions because people are looking for one EMR to rule them all. But I don't think that's how it's going to happen. And people need to get around the concept of interoperability of all these EMRs.
Yes, and that's one question, especially for clinicians. Do you set up your own EMR in your clinic? How do you do it? As well as you also mentioned, even training the secretary will be very important.
Yes, sir. So we actually have had some discussions at the Philippine Society for Digital Health with Dr. Alvin Marcelo on whether we should build or buy our EMRs. And Dr. Esagel was discussing about our Radish, which is a homegrown EMR. But what is important is in the end, the data that's inside these systems will feed into the National Health Data Repository, which under the law will be maintained by the Department of Health and the PhilHealth both.
Thank you, Dr. Iris. And for Dr. S. Sagil, I think some of the burning questions in some people here is, how do they set up Radish or a triage in their hospital or clinic, similar to what PGH has established, or the OCRA system?
The OCRA system was established to provide a consultation. Remember the times na kailangan pipila ka, and then you will set quotas, or you accept all and you end up not going home anymore. So the OCRA system made everything manageable. Okay? So setting it up is not hard as long as you have committed people in your staff to do the scheduling and for the patients to manage their expectations too. Because alam naman natin lahat, lalo na kapag nasa government hospital or government facility, yung expectation na kailangan pag gusto kong pumunta, titingnan ako same day, ora mismo. But we know from national health systems that it doesn't work that way. And that is why I'm very optimistic and I'm really, really waiting for the Universal Healthcare Act to kick into action, because napaka-interesting na dapat merong primary health deliverer ang isang tao. Meron dapat responsible for your primary care. Ayaw na natin na yung pasyente mag-isa ang maghahanap ng siruhano niya. Siya ang hahanap ng rheumatologist niya, ng kay diabetologist niya. Dapat yung system can help take care of that. And we're hoping that, as Dr. Portia said earlier, the local health, the LGU, or the local health centers can partner. In fact, yun din yung gusto namin, ini-envision namin doon sa telemedicine namin noon pa, na hindi kailangan yung pasyente ang maghahabol ng consultation sa PGH OPD kung hindi yung kanyang local health center na nag-aalaga sa kanya, yung primary doctor niya, ang mag-i-establish ng consultation. Kasi baka naman tanong lang ang kailangan, am I doing the right thing? Because we know sometimes if you're in the primary care level, there's some level of uncertainty, baka kulang yung kaalaman ko, baka lang naman, and we can help there. And secondly, eventually kasi, if we're going to really make UHC work, no, PGH definitely magiging apex hospital, di ba? So pagka naging apex hospital ka, ultimately papadala sa'yo yung mga yung medyo complex na hindi na kaya at the primary level. And pag nangyari yun, hindi pwede na ang PGH, ang OPD, makikater din sa simple UTI, simple URTI, and at the same time titingin sa pasyente na may complex anomalies kasi mag-burnout ang mga tao mo, or you end up not yung utilization ba of a scarce resource, and specialty care is a scarce resource. No? So hopefully yun ang maintindihan natin na i-set up natin. If you want to ask for help, nandito lang kami sa PGH. You can always call us and we can show you how we do it.
Thank you, Dr. S. And now, since you brought up the topic of the service delivery network, maybe Dr. Portia can comment on this.
Let me comment first on the other ones. Siguro just to clarify to Dr. Peters, who asked about one database, you have to remember that it starts with patient care. And remember, and therefore, ano ba yung dapat i-share? Diba? So, and therefore, kung kailangan mag-move ng patient kasi kailangan niya ng mas komplikadong kaso, dapat sasama yung datos niya. And that's the importance of the National Health Data Warehouse. So the person is an information, diba? It's big. You're from our own DNA and our own experience of health and our illness, diba? We're one big information data bank. And as we transfer care, dapat sumama nga talaga yung data niya, yung hindi na uulitin lahat ng labs, diba po? Assuming, diba, that all the ancillary services, all those laboratories are actually of good quality. Diba, dapat hindi na natin inuulit yun. So in Taiwan, that's how they do it. Diba? But when the patient gets to be referred, they can actually access the data from the receiving hospital. And if you repeat, say, an X-ray, outside of the clinical practice guidelines, it's the doctor who will pay for it. It's not the health system or the insurance. Yun yung promise ng universal health care. Diba? So, yung mga ginagawa na, naku, kasi ano ko to kailangan ko kumita. Laki lang. So, no, you will now be guided dapat, diba, ng clinical practice guidelines if you want to partake of the promised finance system that backs up the entire universal healthcare concept. Yun. So we look forward to that data warehouse, and not all information is there what is only relevant. So and therefore, kaya nga mahalaga yung standards, diba, na the data that is being moved across. We actually should agree what are those parang data that should be transferred. And this is where our clinicians should weigh in. Diba? Yung may mga bagay na hindi na importante, wag na yun isama, etc. and so on. So, and the conversation really begins with the specialists at this point. Malaking role ninyo in terms of what are these protocols, these terminologies that have to be defined. Yeah, so that's one big important part. Now, sir, in terms of the term now is healthcare provider network or citywide health system or province-wide health system. Again, a typical city should be, or city or province is about 2 million, mga ganun. So make economies of scale siya So in UHC countries, you don't find too many hospitals. You find strategic hospitals and diba, hub and spokes, and many primary care cases, diba? And that is the envisioned area. And you know what, guys? Ang dami pang kailangan primary care facilities, so the government cannot do it all. And ang dami pa rin kailangang general hospitals sa kanayunan. Yan, sa kanayunan. Yun ang mahalaga doon. And right now, parang the ideal is actually being tested, I think. No, in 58, I attended I think 2 sessions where the Department of Health spoke, and they said that there are 58 universal healthcare sites. So this is what they call the sandbox. Inaaral nila how things are, and hopefully they can scale it. But it's limited, diba, to the public system again. And I'm sure a lot of you are in the private sector. Please weigh in the conversation. A lot of you are academics. We have to model what can work. What we did in Hele and the mints, diba? It was with public. Diba? But in Hele, we did it also with a private sector clinic na may capacity for newborn hearing screening for confirmation. So it really starts with use cases where you can actually show that the referral system should be strong. I mean, hindi naman sa lahat, 'di ba, merong mga special na condition na hindi yung geographic yung nagwo-work eh. It's where the expertise is actually there, then it should work, diba?
Thank you, Portia, and for the interest of everyone, Dr. Iris Tan has typed in the comment box some links for this National Health Data Repository Framework. So you may open the links. Maybe you have time for just one last question, which is very interesting, and maybe any one of our speakers this afternoon can jump in and comment on the side of the patients, what can be done for their literacy or their confidence or technology, so that they can embrace telemedicine. Do you have some thoughts?
If I may po, first is for the doctors themselves to demonstrate confidence in the technology. Kasi we have noted, for example, that some will also express their discomfort about the mode of telemedicine, and therefore that actually goes to the patient's anxiety as well. We are trying to develop ways to actually include the patient in the process of telemed. And so, as I mentioned, we have graduate students working on developing a patient guide, for example, in how to take a photo of their joints, so that can be used as an adjunct in rheumatology, telerheumatology. I have a paper that we're still writing that we looked at the process in the diabetes clinic at the PGH. We looked at the audio version only of telemed. And so we're also trying to come up with, like, what do we need to ask the patients and what do the patients need to prepare so that the teleconsultation will go smoothly. So we really have to tell them what is expected of them. They're expected to do so much more. They might need to self-examine themselves or have their relative examine whatever it is they want to show us. And so these are skills that we also need to work with them.
Thank you, Dr. Iris. I'm guilty of that, being one of the doctors who should exude confidence. Any other comments? Yes, Dr. S.
Siguro ang pwede ko lang sabihin is hindi naman masyado nalalayo, no? Yung ating under 40 na demography medyo computer literate na. So mapapansin niyo naman na kapag yung younger na yung pasyente niyo, mas kaya nang makahabol, 'di ba? So talagang sa ngayon meron talaga tayong problems pa doon sa medyo elderly age group natin. Kaya nakakaawa talaga yung feeling, kitang-kita mo yung pakiramdam nila na hindi cannot keep up with the technology. Kaya I keep mentioning local health centers, barangay, kasi kailangan na lang natin sa kanila is aid them in access. Kasi kung yung ating nasa local health center na nagko-cover noong area kung saan nandun yung ating indigent or underprivileged na pasyente ay nandun, sila mismo ang makakatulong doon sa pasyente na maka-access. Diba? Yung i-aid natin and abet yung kanilang consultation. Kung hindi talaga, kasi kawawa talaga yung matatanda na hindi tapos yun nga, wala nga cellphone, wala noong, kahit na yung analog na cellphone, wala eh. So what will you expect? Ramdam yung frustration, no? At saka yung feeling, yung grievance niya talaga na hindi siya maka-access ng healthcare. So I hope at this time, no, na hindi pa talaga ganun kaganda yung ating telemedicine framework, hindi pa talaga ganun kaganda yung internet framework ng Pilipinas. Sa ngayon, ganun muna tayo. But we will get there. Our educational system is working. I think the government naman is doing work as far as yung ating connectivity is concerned. It's been there. And alam mo naman ako, ever the optimist. Malapit na, malapit na.
Thank you, S. And
Oo.
maybe as a last comment, Dr. Portia, maybe you can tell us about the community groups and
Yeah, as a community doctor and somebody who has worked with NGOs, yun. Lahat naman tayo, we start that kind of discussion. And just to share with you, for instance, in telepsychiatry, quote unquote, they don't want to call it psychiatry pa, actually emanated from the MRS, Milenio, Reming, Senyang, Bagyo. Again, in Quezon. Diba? In Infanta Quezon, bumagsak lahat ng mga kinot up na mga puno. No? So, and then the patients with mental health problems, yun, lumabas nga na may mga maraming namatay dahil kinulong, etc. Diba? Nakakulong sa bahay. Yun. Anyway, the point of that story, when they set up telepsychiatry program there, they were working with an NGO. Diba? Because of the trauma that the people, the mental health problems that emanated from that the series of Bagyo, they needed the support of the communities, and it's not only the barangay health workers, diba? So the organized groups also parang connected them, so they became parang patient advocates and navigators so that they can bring them also for consult. So parang yung technology na ginawa natin for DOT ay for TB, which is the directly observed therapy. So ganun din yung ginawa nila for psychiatry, and then when it's time for telepsychiatry, yan. So nagagawa nila yon ng paraan na makakonsulta din sila in scheduled days. So yeah, I think because we work really with communities.
thank you very much. Indeed, it's very, we end this session with a very heartwarming reality that such a small virus has brought us all together. Telemedicine, everyone in the healthcare system, we actually has forced us to go into a healthcare delivery network system, become a little more, address the patient through telemedicine, and in a very, very practical way, deliver the real healthcare we should do and we should give our patients. So thank you very much to our excellent speakers, Dr. Iris Isitan, Dr. Esther Sagil, and Dr. Portia Marcelo. And I turn over to Dr. Tomas.
Thank you, Dr. Isiptan, Dr. Sagil, and Dr. Fernandez Marcelo for the very enlightening session. The College of Medicine of the University of the Philippines, Manila, and its Postgraduate Institute of Medicine present with gratitude the Certificate of Appreciation for your invaluable contribution as speakers. Thank you. For our fourth session, we have Dr. June Carnate and Dr. Gemma Uy as chair and co-chair respectively for the discussion about cancer management during crisis. I am certain that this will pique a lot of our viewers' interest and questions. Good thing Dr. Patricia Alcasabas, a consultant from the Department of Pediatrics, is with us to moderate our Q&A session later. Dr. Jorge Ignacio is the chairperson of the UPPGH Cancer Institute, an associate clinical professor of the UP College of Medicine, and a medical specialist in medical oncology of the UPPGH.
Good day. This is Dr. Jorge Garcia Ignacio. I am the chair of the Cancer Institute. I gave the lecture titled Cancer Care in the Time of COVID-19. I would like to thank the organizers for allowing me to share, because it took me some time to organize my thoughts. I was asking myself why I was being asked to give a lecture about this. I said, perhaps I have a story to tell. And so this is actually a story about Cancer Institute in COVID-19 virus. The news came in insidiously that the virus got out of the lab in Wuhan, Hubei province of China. I guess the nomenclature of virology didn't uh, actually came out like a scary thing because it was named SARS-CoV-2, then eventually called COVID-19, just to emphasize it was not COVID-20. And then WHO made an official statement in December 31 of 2019, declaring the outbreak as a global emergency. And in March of 2020, it reached pandemic heights. In the Cancer Institute, we were starting to make our own survival measures. PGH rose to the challenge. As you remembered, our director took in the responsibility of turning our hospital as one of the COVID-19 referral centers. But then I have to make that statement in our group that despite the declaration that the Philippine General Hospital will be closed, we cannot close our outpatient or our services to our patients. We have to remain because cancer will not rest. And so we cannot rest either. So we are patients dealing with patients' lives because our patients' lives depend so much on the timely delivery of our services like the surgery, radiotherapy, and chemotherapy. The timely delivery of this will affect the outcome of the patients. So I would say between these lines, their lives will be at stake if we do not keep the Cancer Institute open. So this came out, the news, PGH Cancer Institute remains open even as it becomes as PGH becomes a COVID-19 referral center. But it was not as easy as it sounds because the realities of the pandemic are already in here. There is fear of unknown, vastly unknown. There are a lot of things that were unanswered about the virus. Identifying the patients even, especially those who are asymptomatic, the carrier ones. So how do we prevent this transmission? Patient to patients, doctor to patients, and fomites to patients, etc. Things. What are the best measures? There are a lot of things that we really do not know about it. So we kept on reading the news, having updates with the hospital infection committee. But this story will not be complete without mentioning a lot of heroes that has played a good part in this maintaining the Cancer Institute going. Foremost is our former chief fellow of the medical oncology, Dr. Marvin John Mendoza, who actually was able to organize well all the other services and started writing down the rules on how we should go about the flow of patients. I gave them directions, but he made it very clear on the papers what to do for our patients and for our doctors and all the staff. And then we have Carlo Miguel Berba. Dr. Berba is our tech guy. Yeah, he's our direct link to our hospital infection committee unit because he is the son of Dr. Regina Berba. And as you know, Dr. Regina Berba is the chair of our hospital infection committee. So he is direct. We have like a direct link. It's a fast way of communicating and being updated on what to do. And we have our chief nurse, the late Cynthia Orilla. Miss Cynthia, sadly, she was very energetic. She goes around the hospital, even in COVID areas. But suddenly, early on in the fight, we lost her. But things that she left actually were very heartfelt. It's always very concrete in our hearts. All the things that she did for the sake of patients. We deeply miss her during this pandemic fight. And aside from this, heroes, of course, I thank all the nurses, the nursing aides, our staff, the pharmacists, the utility workers, the security guards, even, and our admin staff. These are the things that were really uh, will not be possible without them, without without all of them working together. The Philippine General Hospitals, you would see in the aerial view, the this is the Centro Oftalmológico Jose Rizal, and this is the Cancer Institute, the one with a garden inside. It is fortunate for us to have our own building, and it came easier for us to isolate ourselves from the rest of the Philippine General Hospital. So we made it a way that our Padre Paura gate became our entrance and exit, and we closed the other door that's coming from the PGH, so we're able to manage our flow of patients very well. But you can see there in the entrance, even our security guards were wearing all the PPE at the very start of this pandemic, because we really were very, very afraid of anybody getting the virus. And so we set up. We also were fortunate to have a very big driveway in front of the building. So we converted that to our screening and holding area. As you can see there, uh, there were a lot of barriers that we put up, those vinyl barriers. We had tents in front. And we even have our own swabbing area because we thought that we have to swab all the patients coming in. So there was a big task of doing all this swabbing actually in that area. Yes, we did. We tried to smile during those days. Even there's the the feeling of the fear is really there and palpable. But we also have to be seriously taking care of our patients. And this experience were also new to us during the early days. We really don't know much. We have to interview our patients if they have symptoms about it. So a lot of screening. And when you enter the building, there's this weird emptiness inside. This is the first time in all the years that I've been in the Cancer Institute. It's the first time that I felt that emptiness, because I was always been seeing our Cancer Institute beaming with people, all the people inside being full, all the clinics. But those days, in the early days, as you can hear your voice echo through the halls. And well, as the months wore on, it was wonderful thing that happened. There was something very, very unexpected happened. In a way, the mutations that came through to the virus was like a blessing. It started like uh, being tamed in a way, and I would say it from a very, very virulent virus. And then suddenly the virulence started going down. And together with that, of course, the recommendations on the protective equipment or the clothings actually started getting shed. First and foremost, were uh, the suit came out, and then after that, those face shields, the controversial face shield came out, and then there were we came in, and but we maintained, of course, the mask was maintained. Um, some of them were kept the face shield still, but we were able to manage ourselves very well. Well, the problem is like in those days, uh, the budget for COVID is given mostly to the COVID areas. We were not a priority in a way in the budgeting for COVID. So we were like, well, I would term it leftovers from the hospital. But while we are wanting in that from the PGH, we are not really wanting in numbers of PPE and alcohol and everything because a lot of friends from outside came in, pharmaceutical friends, uh, old and new, came with uh, boxes and boxes of supplies. So we never ever, even to this day, we never actually ran out of all these supplies. And well, even the hand washing, which is actually, I would term it to be the most important thing in the infection control, and I would say it's the most consistent in a way of controlling the transmission. There is a foundation that actually built hand washing stations inside the Philippine General Hospital, and we got one inside the Cancer Institute as well. So that is another thing that was added to. Together in parallel with this one, the telemedicine actually was started, and we started also entertaining uh, telemedicine called consult, and it actually came very handy in some of course who are has some computer literacy, but we know for a fact that not all of the sectors will be reached by this telemedicine, so we kept our clinics open even for walk-in patients. I believe that what is our in this all the challenges, the most important thing is coordination, the assignment of rotating teams of personnel to lessen the exposures of the personnel all at the same time. So we had teams in each clinic and even the nurses. So we don't have to like one time there's a whole team that was exposed, so we have to quarantine all of them. So we have to really be careful and make those rotations very efficient. So there are a lot of things that came in, but coordination is very, very important. Vigilance also, of course, a regular meeting, open communications, vigilance, and use of availability of all the uh, PPEs and all the materials. So that happened that we had, of course, as the uh, virus war on, we have a holding area in front of the PGH, and this is how my office looked like, and still looks up to this time. Looked like a storage place actually, but I don't really mind. But it kept us going. As I said, we were not wanting in all this PPEs and everything. So well, surviving has this blessing of looking at each day as the day and just surviving the day. So we were swept all in those things. As the days wore on, days turned to weeks, weeks turned to months, months into years now. And now we were back to our numbers from less than 50 before in the early days of the pandemic. We were back to our regular numbers of like 300 just in one clinic, especially for medical oncology. So we're looking at in the whole picture of Cancer Institute, like about almost 500 patients each day, back to the numbers pre-pandemic. But that is our what we have sent us a message. We are here and we will never ever rest. We have to really give our all. So, but aside from that, of course, we still have the vans, our mobile cancer screening vans still on hold. But I asked the permission of the director if we'll be able to reactivate the vans because I know for a fact that the people in in some barangays, even in Metro Manila, are not coming for screening. Filipinos wait for problems to come out, not to prevent them from coming out. So we really have to reach out to all these sectors that we are they are very vulnerable. So the plan is to move out once more the ban. So I encourage them to be as normal as possible, but we still maintain our measures to keep the transmission from getting into uncontrollable proportions. So they're back. Our donors were back. They're sharing with our patients. If we look at our patients, we have to keep them hoping. Hope is what keeps them alive. And I guess that is what we are there for. We are there to show them, as the Philippine General Hospital Cancer Institute will never abandon them in all these challenges that happens in their lives. We we will always be there for our patients. We have to give them back what they really need. They need medicines, they need service, and that we will never ever rest because their cancers will not rest. Give them hope because that is what they are look for when they come to our clinic, the Philippine General Hospital Cancer Institute. All these things will not be possible if we do not put our efforts together. You don't. We cannot survive without the support of everyone. So I thank also the administration, how they handled all the donations, and they're able to reach even us as well. There was food actually was tremendous. Never lacked for any food during those days. And I thank really all the other doctors who gave all their efforts, the nurses, the staff. Cancer Institute will be there for all our patients and will always be. Pandemic or no pandemic, this is our commitment. We will always be there. So, maraming salamat po for allowing me to share this story with you. This is Dr. Jorge Garcia Ignacio of the Cancer Institute.
Dr. Karine Garcia is the chair of the Department of Family and Community Medicine of the UP-PGH and also the chair of the Department of Family and Community Medicine of the Manila Doctors Hospital. She was also a member of the Technical Working Group on the development of a Manual of Operations for the National Hospice Program.
Good evening. I will be providing the lecture entitled Cancer Management During Crisis. First of all, allow me to thank the organizers for the invitation to be one of the speakers, and my congratulations to the UP College of Medicine Postgraduate Institute of Medicine for celebrating the 23rd Grand Scientific Symposium. These are my disclosures. This is actually a non-promotional lecture intended for healthcare professionals. I am an invited speaker and receive honorarium for pharmaceutical-led lectures. And I am a family and palliative care specialist from both a government and a private hospital. So most of the elements of this lecture have both primary care and palliative care aspects and flavors or essentials. And I only have 3 outlines. First is I will discuss the impact of cancer care during the COVID-19 pandemic. What are the lessons and modifications made to ensure crisis preparedness in cancer care, and how to develop strategies to ensure crisis preparedness in cancer care? For topic 1, the impact of cancer care during the COVID-19 pandemic, I was tasked to provide observations on the number of referrals during the pandemic compared to the pre-pandemic period, and also to provide observations on the modifications made due to the pandemic of ongoing care and their effects. So let's start first with what is known. Patients with cancer may actually be at an increased risk from a pandemic infection because of factors such as old age, comorbidities, and the immunosuppressed state. There is also an increased risk of severe complications of COVID-19 disease or ICU admissions for patients who are COVID-19 patients with cancer compared with those with COVID-19 disease and without cancer. And lastly, there is an increased risk of death in patients with COVID-19 disease who have cancer as compared with those without cancer. And looking at this, it actually increases not only the morbidity, but also the mortality, and also it increases the chances of having the infection if you have an immunocompromised state, such as cancer. Now, what are the health system's capacity components and potential changes during a pandemic? So I know we have a lot, but I actually focused on 4 components of the health system capacity. And let's look at how it was increased and also how did it show potential decrease during a pandemic. Looking at hospital and ICU beds, we are aware that more hospital beds are available because of factors such as cancellations of procedures, surgeries, there is reallocation of beds, there are regional networking of hospitals, and use of private hospitals to increase public system capacity. Now, there is a depleted availability of hospital or ICU beds for non-pandemic patients. Kasama dito, including here, are cancer patients. What about our health staff, including those who work in the oncology unit, our health professionals and allied health community workers, or even our NGOs? There is an increase in healthcare staff because of factors such as surge in capacity availability and redeployment. I'm talking in general, but there is a decrease kasi some of our staff get infected, are on quarantine or on isolation, and they get redeployed. So in other areas, so if you are in an oncology unit, you have to also serve our COVID-19 floors, okay? Looking at medications, including medications for COVID-19 and oncology treatment, there is additional procurement of medication to meet increased demands, but the demand for COVID-19 patients exceeding supply during times of high infection, supply chain issues, and depleted availability for non-pandemic patients. So systems and capability for coordination. We know coordination is really needed in cancer care and sharing of resources. So there is greater capability in response to the demands of the pandemic progression, but looking at its pitfall, there is workforce depletion here, redeployment, and burnout. Okay, so what are the observations in terms of our referrals? So looking at the section of supportive hospice and palliative medicine, where we actually see pediatric, adult, geriatric patients, those with a chronic debilitating illness, including cancer. So as of 2021, at least 60 to 70% of the referrals from all the wards are really cancer patients. So that is very impactful, as even during a pandemic, our number one or the top most referrals are from cancer patients. And the section during the surge provided to be the liaison to the family, specifically for COVID-19 patients, but for cancer patients, they also have to do that because of less visitations and decisions for families. So that was the service allocated for the section. Okay, now let's look at the impact of the pandemic on cancer care. I'll focus on the service allocation and also the healthcare provider. So it was noted that there is a delay in screening, diagnosis, and treatment during the COVID-19 pandemic. We have a decrease in screening rate, delays in diagnosis, reduction in the number of cancer surgeries, even using radiotherapy or other regimens, and delay, rescheduling, or cancellation of OPD visits. Of course, this happened, and I know you are all aware of the situation during the surge or during high infection rates. So this table actually shows us a comparison between the decision regarding immediate cancer treatment during COVID-19 crisis, looking at low, intermediate, and high risks, and also the chances of developing morbidity from COVID-19. And it's divided actually into age, less than 50, 50 to 70 for medium, and high is actually more than 70. So if it's low, meaning it's safe to delay the treatment for more than 3 months, it's different. No, this is surgery, radio, and chemotherapy. So it's telling us to actually delay the immediate treatment if it's possible. Okay. Now for intermediate, meaning delay of at least 3 months or more, for low, less than 50 years old, we have to proceed with the immediate treatment, because there is a risk of progression is intermediate here. For medium, you really have to look at the balance of the risks and benefits. And if you are more than 70 years old, the risk of developing COVID-19 is high. We have to delay that immediate treatment. Now, if the risk of progression is high, ideally there should be no delay. So for low or medium risk, we have to proceed. But if it's high, then the decision between risk and benefits of immediate treatment is important. Okay. All right. Second impact. The first impact I told you about the service allocation in terms of screening, diagnosis. What about the impact on follow-up and supportive care? This is very crucial, specifically during ongoing treatment. Okay, so there are delays or cancellation of follow-up appointments, modification of follow-up plans. Sometimes it gets suspended, and we noticed that there is an increased use of telehealth services, but there are missing social support, which is integral during this time, from family and friends, lack of access to social support services, and unfortunately, hospital is restricting visitors during the surge or during this time. So it affects our cancer patients. Okay, looking into health professionals, those who work on oncology, allied health and healthcare professionals, we all note this risk of distress, there's burnout, not being able to do the job, and disrupted practice. Okay, So we're done with topic 1. Now let's proceed with topic 2, looking into lessons and modifications. I'll focus here more on the impact of telehealth, telemedicine on cancer care, and utilization of home-based medical and ancillary services for cancer care. So the question here is, teleoncology a viable alternative in a health crisis? So yes, looking at this risk-adapted model, so we divided patients into, if they have completed treatment and are on follow-up, then it's advisable to actually continue teleconsultations. If they're about to begin treatment, whatever kind of treatment, it's a combination of your decision. No? You have to see the patient and follow up in person, but on occasional basis. If it's an ongoing treatment, of course, there are a lot of things we need to look into here. How's the patient, adverse effects, and everything. So in person for initial, then as needed consult thereafter, just like the second one. But they have to continue reporting with teleconsultations. Okay, so that's for telehealth. Now, what about home care? Okay, so just want to show you what are the benefits of doing home care in general. Okay, it actually enhances the quality of care for patients and supporting family caregivers. It empowers the family. Okay, it ensures control of chronic conditions by managing the symptoms, whether it be physical or psychosocial symptoms. It decreases the need for emergency room visits, readmissions, or acute hospitalizations because it provides very strong anticipatory care. It reduces the fragmentation in care complex of chronic conditions. As you go home, everything should be managed at home, the totality of the patient. But if needed, then we have to call other members of the multidisciplinary team handling the patient. And lastly, it helps alleviate stress and other challenges for everyone involved in the patient's care, not only from the patient, but in everyone. Okay. So home care services, we have basic home care services such as when we transition from hospital to home, including home care setup, managing these symptoms at home, coordination of referrals to other specialty or ancillary care if needed. It includes nursing and bedside procedures and counseling. Specialized care, if symptoms seem uncontrollable, then management of refractory symptoms, strong on family meetings, advanced care planning, goal setting. These are more of palliative care, home care services, end-of-life care, grief and bereavement support. Now, the service level allocation that I would like to share to everyone talks about palliative and hospice care services across the different levels of care. And it's actually very applicable to cancer care. Okay, so at home, looking at the first box, patients should be able to receive hospice and palliative care, end-of-life care if needed, nutrition services, and all of this. Okay, so it helps the family. Okay, we need to empower the family. But going up, if needed, okay, the communities should be able to provide the needed services from the patient and the family. Okay, pharmacy is there, other support services, telehealth, standalone palliative care, long-term facilities. But this one, if there is an emergency care, there is a need for inpatient care, radiologic care, or respite care. No, sometimes our patients and their families will be needing a break. Then it should be the health facilities in the hospital. So during the COVID pandemic, the surges, this is the third box is the one that is really affected. So we have to really empower the homes, okay, our community palliative providers so that they can provide the basic services needed for those with chronic conditions, including cancer. I'll discuss more of transdisciplinary approach later. Okay, so we're down to topic 3, okay? Developing strategies to ensure crisis preparedness in cancer care. Okay, so I've mentioned that the changes in cancer care delivery had included the use of telehealth, innovative care models, and impacts on cancer research and clinical trials. Okay, so current guidance and evidence support the importance of 7 key principles underpinning optimal cancer care during a pandemic. And this includes the provision of patient-centered and family-focused care, safe and quality care by minimizing the risk of a pandemic infection for patients with cancer and the healthcare staff, looking into transdisciplinary care, supportive hospice and palliative care, care coordination, communication, research, and clinical trials. So ito yung 7 principles that we need to ensure that it's there, the strategies, so that we can provide the best cancer care even during a pandemic. And we'll go through that one by one. So first is patient-centered and family-focused care. We know that the treatment should be individualized, but the family is there with the patient to decide, because they need to do shared decision together with the members of the multidisciplinary team. And the family and the risk and benefits of any changes of the treatment plans should be discussed with the patients and their families. Okay, what about safe and quality care in a pandemic is a key consideration, and it should be provided in the safest way possible. I discussed earlier the optimization of telehealth services and clear information and communication to particular settings. So that's the second. The third is looking into transdisciplinary care. This is actually the most prevalent model, which calls for one team member to provide the interventions, and members of the transdisciplinary team cross professional discipline boundaries to achieve actually that service integration by consulting one another. Okay, so they have to teach each other. Okay, and the staff and the family members actually plan together based on functional assessments. We consider the family as is valued actually as an active member of the decision-making roles. And what about supportive hospice and the palliative care? It's actually one aspect that needs to be addressed, okay? Because during the pandemic, there are a lot of psychosocial distress that happened, okay? And strategies are employed here to actually help our patients in terms of being vigilant to screen for the presence of anxiety or depression, improve communication of changes to cancer care plan, provision of timely information and guidance. This one is critical a strategy. And I just would like to share that in the integration of hospice and palliative care along the course of a patient's illness, when is it actually needed? So in terms of cancer care that has long-term chronic complex condition, followed by an advanced chronic condition and the terminal state, okay? So there are different areas that we need to focus when we are on that stage of a long-term chronic complex condition. And it has to be from the very beginning integrated already, because even though it is disease-centered and survival is important, we also need to assist in terms of having shared decision-making, building the confidence between the patient and the multidisciplinary team. Advanced directives are already in place, looking at disease and care management. Now, if the condition becomes advanced, okay, this is the first transition actually, then you are now looking into conditioning and quality of life, looking into multidimensional assessment, not only the physical, psychosocial, but including the spiritual. Discussions on advanced care planning, values and preferences are actually already integrated, and crisis prevention or anticipatory care. This is where the most stressful for patients, for families, and the team because it's an up and down kind of situation. Now, if it's the terminal condition already, then quality of life, essential needs, we're looking now into conditions at hospice care, bereavement, nutrition, hydration, sedation. Okay, so I just wanted to share to you this diagram so as to show the importance that it has to be from the very beginning supportive, and hospice and palliative care should be integrated. Okay, care coordination is looking into clear documentation, and communication has to be truthful, compassionate, and honest. And it includes information about cancer treatment, patient preferences, changes in treatment plans, values, goals, and health directives. And the research and the clinical trials. So it has to be compliant with or adherence to regulations and guidelines, even during the COVID-19 pandemic, and standards are actually necessary. So those are the 7 areas, what are the principles that we need to ensure to provide optimal cancer care and how to apply it. And I think that's one of my last slides. Okay. And my take home points for all of you is that the COVID-19 has actually transformed many aspects of healthcare in oncology. There are new, worse, and more complex challenges in care to patients with cancer. But the bottom line, there is actually a need for clear and compassionate communication. So in all the journey of our patients, specifically during a crisis, communication is essential. And with that, I thank you. Thank you so much.
Receiving our audience's questions live, our 2 speakers, Dr. Jorge Ignacio and Dr. Karine Estepa Garcia, will enlighten us on hospital-based and home-based medical and ancillary services for cancer care in a time of crisis.
Hello, everybody. Good afternoon. Thank you very much and for your excellent talks, and congratulations, Dr. Karen and Sir George. So thank you very much for painting the picture of our dilemma and crisis and problems. And I was looking at the internet while you were talking as well, and I realized there were so many publications on cancer coming from the PGH staff during COVID and cancer. And when we were looking at the registries, for example, for Gynae Onco, 2019, 897 cervical cancer, ovarian cancer, but this dropped to 597, or roughly 25%, 30% in 2020. But now the numbers are picking up. So let me just read the questions that were answered already, but one is about the oncology training. As you know, PGH, apart from service delivery, has the mandate of providing research and has the mandate of providing training. And so we also provide training for the ancillary medical cancer services, just like pharmacy. And Dr. George, would you know when they resumed the training for oncology pharmacy, and what other services? Was the medical oncology training stopped during the time of COVID? Was it changed a little bit? The curriculum, for example, or anything like that? Thank you.
Yes, thank you for that question. The training actually, aside from having problems like the rotation with COVID, because hindi naman na-exempt kasi yung mga fellows. Hindi sila na-exempt sa COVID rotation din. So aside from their from their cancer institute duties, they also have the COVID rotations. That was at the initial onset of that one. So patuloy din, if you will compare our numbers of patients to the other institutions naman ng training, marami pa rin ang ating exposure sa pasyente natin. That's the reason why hindi naman masyadong bumaba yung ating census. Well, initially, of course, as expected because of the fear of patients to come in, talagang kaunti. Pero as you know, after when the virus eased up, unti-unti na umakyat na talaga rin numbers. So there is no need because we were asked also if we will extend the trainings of our fellows. So I said as of the numbers of exposure of the fellows, I am talking in particular also for medical oncology fellows. Hindi kami kulang. I think the other specialties like gynae oncology needed some extension because they lack the numbers in their patients. So merong mga iba-ibang specialties, iba-iba yung nangyari. So I cannot speak on a general term, but the numbers actually, kung numbers ang babasihan, yun yung naging reason for extensions for other specialties. Well, that is acceptable actually in a time like that because it's not a normal situation. Tapos yung the pharmacy right now as you've seen that we have actually right now 4 compounding biosafety cabinets. Our dilemma is to the number of pharmacies that were items yung hired. But now we are opening to other institutions. Pwede na silang mag-schedule ng training for compounding.
So thank you very much, Dr. George. And so for Dr. Karen, I really like your talk on transdisciplinary way, because with this medical migration that's happening and nursing migration that's happening, and with the development or establishment of community-based palliative care, right? There comes this need for task shifting, wherein you really need to train lay person instead of a nurse to provide palliative care. Can you talk a little bit more about the MOPS? What is this all about? Is this all about training laymen for cancer palliative care in the community as well? Thanks.
So thank you, Dr. Tricia, for that very significant question. Yeah, the palliative community or primary palliative care community identified the need, specifically during the pandemic. How can we actually take care of our patients? And it's really hospital-centric in some areas. So there was that need to actually empower the community in taking care of our chronic and debilitating patients, like example, if this is cancer. And this was actually recognized as an essential need by our Department of Health. Thus, the creation of the Manual of Operations for Hospice and the Palliative Care. This is to actually teach the people from the community, okay? And that's what we call actually compassionate care. It actually starts from the family, the basic unit, okay? And from that, teaching them how to take care of patients at home, giving them that skills, because lalo na pag na-pandemic, they cannot go immediately to hospitals. So what can they do at their level? Now, pag hindi kaya, and if there is more need for, higher care, then the community should actually be empowered to help them. And those areas in the community that I've mentioned will actually include not only the healthcare workers, but the pharmacy, the diagnostics are available, even telemedicine. And saka lang yan aakyat sa taas kung hindi na talaga kaya down that level. And I think that's the significance of that, that manual of operations, because now, Dr. Tricia, we also have our basic and advanced courses for palliative care. Not only focused on doctors, but also sa lahat ng nag-aalaga ng ating mga pasyente who have this debilitating illnesses. The nurses, the medtechs, social workers. So, yon. So, Thank you. Over.
Yes, magaling yan because, I was just talking with my team and we were discussing how many of the Catholic churches have these groups like Legion of Mary that do have that mission to take care of the sick. And they are a good group to train, right? Because they do home visits, diba? Ganyan.
Yes.
So, going back naman dun sa hospital, Dr. Ignacio, I realized that when we want to sustain the initiatives and the support of the community, right, in terms of donations, right, for our patients, in terms of blood donations and blood drives to our patient, what are you doing? What is the PGH doing in order to sustain that? Kasi kung alam niyo lang po, tumaas talaga ang community support during the time of the COVID dahil isang bangka lang tayo during COVID, di ba? So ngayon na it's been 2 years, going 3 years, medyo nag-wane down na rin medyo ang support. Yeah, thank you.
Yeah. In Cancer Institute, natutuwa ako actually. It's a welcome thing that the private institutions, the organizations, talagang maraming dumadating pa rin up to now. Although hindi na katulad nung dati kasi even just barkada, no, ng mga friends lang, and then even individuals on their own just bring food and then they drop it off sa Cancer Institute for the staff, no, for the doctors, nurses, everyone. Actually, we have really overflowing at those times. I think nakita rin naman, na-realize nila na hindi na yun yung need ngayon, no? So it changed, the needs change, and so we still allow. What I do is to always be interactive with all the donors. No, gusto ko nakikita nila ko at least nila na we appreciate what they're doing. Yun nga, no, sometimes medyo yung times na kailangan na hindi daw sila magkaroon ng interaction, but at least I tell them we manage the interaction with patients because it actually uplifts also yung pagka nakikita ng donor kung sino yung dinodonate nila, o yung nakikita nila mismo yung joy sa faces ng mga patients when they give the whatever yung kanilang food or mga regalo na binibigay, especially now that Christmas season is coming up again. So yan it's how to sustain the spirit of these donors. Kailangan makita rin nila na especially now with social media, we have to show it, no, na merong mga patients na ganon na who will spend Christmas in a different way as how they experience Christmas is. Yun nga, katulad ng mga Christmas wishes natin sa Christmas tree, no? I always tell them, you'll see Christmas in a different way through the eyes of this patient. But last week, yung isang wish is, I wish I can see this Christmas. So it's even more difficult to explain to donors that some of our patients lost their sight due to cancer. So we don't even see how it is, no? But it always be felt by donors. That's what I am after, actually. Let them feel how they're feeling right now. That it sustains them.
Thanks, Dr. George. So there is a question in the chat where we can send people for training on palliative care.
Yeah. For training, actually, like what I mentioned earlier, Dr. Tricia, we will roll out the basic provider course and also the intermediate course under the Department of Health. So it's part of the primary care series of lectures. So it's still coming to roll out. It's still going. This is for all, no? But for doctors, there are different ways of actually going into training for palliative care. We have here in the Philippines, we have here fellowship training, but there are also observerships and in other countries as well. So I think it's varied. It's available here and also abroad.
Thank you. So, I'm a pediatric oncologist, and one of the need that is we need to address, is how to provide chemotherapy to COVID positive patients who are still under isolation or quarantine, right? Because otherwise they're clinically well, and in other countries they are given chemotherapy. So I was thinking, how do we scale up our services to provide COVID treatment for chemotherapy for COVID positive patients? Have you talked about in PGH, Dr. George, about creating a COVID cancer ward, for example, or COVID cancer service? And what are the steps that we need to do in order to, I think this is something about, we are still in a crisis, we are still in a pandemic. And then moving forward and scaling up, we need to create this kind of service delivery. Thank you.
That's true, no? As you've seen, no, some COVID patients are really asymptomatic. And yung iba nga, 1 month na positive pa rin yung swab, di ba? So what do we do with patients like this? Because that will affect the treatment schedule of these patients. These patients cannot delay their chemotherapy. There are situations where you don't have the luxury of delaying treatment, even the radiotherapy and the chemotherapy. I think there was a study actually that showed that the chemotherapy does not really affect the course of the COVID virus, especially for asymptomatic patients. The radio oncologist actually asked my permission on scheduling COVID-19 positive patients. So we did that one. So they were scheduled actually late in the evening. So some of our patients who are COVID-19 positive were scheduled in the evening. So it will not be together with those who are non-COVID patients. So we continued on those patients. But of course, I think what we should do right now is to gather those the data that we had about those patients having treatment despite having positive COVID-19, because there is no documentation, there's no real study that can help us make a guideline for this kind of patients. So I think, especially for pediatrics, I think many pediatric patients would fall on those asymptomatic COVID-19 carriers. So I think we should gather this data and be able to more or less help make guidelines for this kind of patients.
Yeah, that's a great idea, Dr. George, because I saw some publications about shifting the kind of surgery because of some because of the COVID situation at the time ng mga 2020, and shared care publications, on how they share delegated and transfer the care of these patients into the community. So my question is on the national level. How do you, how we doctors of PGH will be able to address, this the healthcare delivery crisis for cancer patients at this time of the pandemic at the national level? One problem that arose is manpower, right? Manpower, there are less number of nurses, less number of doctors, less number of residents, right? How do you think we should address this? Should we do any initiatives at the national level, right?
That's wonderful. I think Dr. Karen said about empowering the lay on the care. So if there are those who would not really need hospital-based treatment, then we can actually activate the barangay health workers or some NGOs to be able to help them out with those with this kind of patients. But the number, of course, we are beholden to to the number of items that we have in our institutions, and it's not easy to just add on to this number of residents, nurses that we have, especially now that nurses are going abroad once more, and we're losing a lot of a lot of our nurses to the US, the Europe, elsewhere. There's a ongoing migration right now, but then we'll still not be lacking in a way, because there are a lot of those who are applying. But now that we see that more patients would really need a lot of these things, I think what we can do is to add on through other institutions, like let's tap some donors outside to finance more patients, more personnel, additional personnel in levels that can help in our cancer management. What we need is like navigators. We need a few more nurses to add on to our list, but we really have to also make we that's a little bit complicated as it sounds, because we really need to have a memorandum of agreement on their responsibilities and the PGH responsibilities to them. Also, those are the things that we have to tackle, but that is still doable in a level of the director's level, actually. So it's wonderful to think of. A bit complicated, but it's doable to tap into all those NGOs, some philanthropists who can add some more to the numbers of personnel inside PGH. And of course, as Dr. Karen has shown, the other patients who can be put into the community level, of course, they can actually empower. Just the coordinations will always be the key on those kind of patients.
Yes, thank you. Yeah, if I may add to that, Dr. Tricia and Dr. George. So yeah, it's really essential to capacitate our community. But looking at it from PGH, from our side, we are seeing a lot of patients coming from the provinces, coming from outside our networks. So I think it's really important to actually strengthen the oncology network, down to the community level, from primary care, oncology, until hospital. They get lost in that system, yung navigating the system on how they would be managed from the onset of the diagnosis to their treatment, and then to their prolonged care or probably end of life. Yun ang medyo scary, and the patients and their families are really anxious. So perhaps in a national level, we can look into that, because that network that we can have is something that will be valuable for these patients. And even as healthcare providers in the communities, we know where to refer our patients. So yun, that's my addition to that. Thank you.
Yes, thank you very much, because indeed, the referral pathways, the patient navigation, they are all in the cancer law, right? In the cancer law that was signed in February 2019, the NICA, and also in the universal healthcare, wherein everybody should have quality healthcare at no financial distress, right? So I was thinking we had a national meeting for pediatric oncology, and the talk of Mayor Dr. Alcantara was on universal healthcare for pediatric oncology, wherein she emphasized participatory governance, which means that in our country, wherein our health system is kind of fractured for all things, not just cancer, that there is a huge role of the technical people, which is us, right? The civil professional societies, the universities, right? In order to start and jumpstart for example, the referral pathway and shared care. And I think that also having a lot of advocacy kasi medyo maingay tayo, advocacy with the parent groups or patient groups that we work with in order to promote that. So I was thinking then, are there any Are there any policies or any laws that you think we should advocate for? I really appreciate PhilHealth on how they actually lifted the limit, right, to usage of PhilHealth for almost 2 years until ngayon, December 2022. No longer is there is no longer any 45-day gap, right, for you to use your PhilHealth for chemotherapy, for radiation up to December 2022. We are implementing that in PGH, and I hope other private hospitals are implementing that as well. But I was wondering, in your side, is there anything that you think we should advocate for? Looking at, for example, manpower, medical migration, access to medicines, right? Registry system and other dimension of the healthcare system for cancer that we should advocate for. While there are 676 participants in the group that might help us advocate. Thank you.
Si Dr. George, baka.
I think yes. First, of course, the most important one, as you already mentioned that one. Since you mentioned it, the cancer registry is one thing in a lot of things, though. Wala pa tayo na-establish talaga na national cancer registry, but there's one actually outing, of course, with under Dr. Trixie Tiangco, the CARE. But now we really need to support it, and I think with more support, it might be able to reach community level. Right now, it's still hospital-based, mostly hospital-based, but what we need more in an area is the community side. Now, yes, and I think what we do not really see in a concrete way. Kung pumunta ka sa ibang bansa, maraming mga wings dyan na merong pangalan ng mga private individuals who, donated this wing for pediatric cancers, for another wing for etc. etc. So if we can be able to tap them, organize them, I think there are a lot of those who are willing to give, so long as they know kung paano nila if we'll be able to organize them, I think we'll be successful in changing or making better our cancer delivery services for everyone.
Thank you. Dr. Karen?
Yeah, I think universal to us is really the universal healthcare. So it actually not only talks about service delivery, but it's also looking into capacitating our healthcare providers, and that framework of providing promotive, preventive, curative, rehabilitative, and palliative care. It's actually there already. So we're just hoping that we're in the middle of the implementation, and the cancer bill is there, but we also need to really look into how the implementation of universal healthcare will be, because it will really impact also our cancer care. Thank you.
Thank you. So let me just read a question. If an efficient system or referral or an interconnected system is to be created, then would this not require a government mandate or funding?
Yes.
Yes, I believe, right? Agree.
Yes.
I think that is also the provision in the universal health care.
Yes.
Meron namang law on that one. It really needs the implementation part. It's the one that we have to work on. Of course, this would really need a lot of budget. Yun ang kasi reality. We have to, of course, it boils down to the reality na it would need logistics, like people working on that one. Of course, we need a good way of communicating, whether it be by internet or whatever. Basta meron tao. Navigators will be very, 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 very crucial. A team of navigators that will be, even from a community level, meron silang communication with the navigators also in the hospitals, things that can happen, that will facilitate a lot of things
Yes.
for us.
Yes, and I think Dr. George, important here are the stakeholders. We need to
Yes.
really look into who among them and the level of the community, who can we tap? Because even if it's from above, if there's no, help from below, from the grassroots, from the community, mahirap din talaga ma-implement. So we need, what is the term? But we need people who are
So
advocates.
LGU, right?
Yeah,
Yes.
advocates from the LGUs down to the communities that we can tap
Yes.
into. Yeah.
Thank you. Thank you. With that, let me just summarize. I agree that the government needs to give funding to implement the law. But when you really look at it, who implements that? It is us, the doctors on the ground. And when you look at the implementation, for example, of a Z package, there are a lot of inefficiencies. There are a lot of low effective coverage, right? And a lot of violations. And that also reflects on the kind of care and hospital operations that we provide. So I was thinking that isang bangka lang tayo. If we do isang bangka para sa COVID and it's very successful, isang bangka pa rin tayo for cancer care here in PGH and in the Philippines. So thank you very much and congratulations. Excellent talk. Thank you.
Thank you.
Thank you.
Thank you, Dr. Ignacio and Dr. Garcia, for the very informative session. The College of Medicine of the University of the Philippines, Manila, and its Postgraduate Institute of Medicine present with gratitude this certificate of appreciation for your invaluable contributions as speakers. Thank you. That concludes day 2 of our symposium. Without a doubt, we've covered a lot of ground, from emergency management systems, telemedicine, best practices in healthcare delivery, and the answers to your questions. Our speakers have brought us a wealth of knowledge, and we are expecting more as day 3 approaches. We have 1 day left and are counting the hours until we see you all again. Please don't forget to scan the QR code or click the link in the chat box to answer the evaluation form for day 2. Thank you everyone, and we hope to see you on the 3rd day of the 2022 UPCM Grand Scientific Symposium.